சார் நல்லா இருக்கீங்களா சார்?
நல்லா இருக்கேன். என் வீடியோல ஏதோ ப்ராப்ளம் இருக்கு. வீடியோ வரல. ட்ரை பண்ணிட்டு இருக்கேன். இல்லன்னா வேற இதுல இருந்து வரேன். நோ ப்ராப்ளம்.
சரிங்க சார், சரிங்க சார்.
அப்படியே இத வெச்சிட்டே ஒண்ணுல.
சார் இப்போ எங்க பாலாஜில இருக்கீங்க? எங்க சார் இருக்கீங்க?
ஏசிஎஸ் மெடிக்கல் காலேஜ் ஜாயின்ட் டீனாவும் ஹெச்ஓடி பீடியாட்ரிக்ஸ் ஆவும் இருக்கேன்.
ஓகே சார், ஓகே சார். வாங்க சார் தர்மபுரி.
கண்டிப்பா வரணும். ஏன்னா நிறைய பேர் தர்மபுரில இருந்து ஏசிஎஸ்ல இருக்காங்க.
அப்படியா சார்? சரிங்க சார்.
ஆமா, தர்மபுரி கார்டியாலஜிஸ்ட் வைஃப் இப்ப இங்க பீடியாட்ரிக்ஸ் ஜாயின் பண்ணிருக்காங்க.
ஓ சரிங்க சார், சரிங்க சார்.
இன்னும் 2 பேர் கூட தர்மபுரி தான். இங்க ஒரு அசோசியேட்டோ ஒரு அசிஸ்டன்ட்டோ வீடு தர்மபுரி. சரி, அதுக்காக அங்க வரணும். வரேன், கண்டிப்பா உங்களை பார்க்கணும் வந்து.
வாங்க வாங்க, சொல்லிட்டு வாங்க சார், கொஞ்சம் அட்வான்ஸாவே சொல்லிட்டு வாங்க.
கண்டிப்பா கண்டிப்பா
சார். உங்களுக்கு வாட்ஸ்அப்ல ஒரு இமேஜ் அனுப்பிச்சிருக்கேன் சார், பாத்தீங்கன்னா உங்களுக்கு தெரியும்
சார். அரசு சார் வெல்கம்
சார். குட் மார்னிங். குட் மார்னிங்
குமார். யாருக்கு அனுப்பிச்சிருக்கீங்க? என்ன இமேஜ்?
இல்ல அரசர் சார்.
மேடம் வெல்கம்.
கோபால் குட் ஈவினிங். கோபால் குட் ஈவினிங்.
குட் ஈவினிங் சார். குட் ஆஃப்டர்நூன். குட் ஆஃப்டர்நூன். குட் ஆஃப்டர்நூன்.
ஆஃப்டர்நூன் மேடம்.
குட் ஈவினிங். குட் ஈவினிங்
மேடம்.
நல்லா இருக்கேன், நல்லா இருக்கேன். குட் ஈவினிங்.
குட் ஈவினிங்.
குட் ஈவினிங் மேம்.
மேடம் எப்பயும் இன்ட்ரோ 16 மாதிரி அப்படியே இருக்கீங்க மேடம்.
தேங்க் யூ.
குட் ஈவினிங் மேடம்.
குட் ஈவினிங் ஆரு சார்.
டாக்டர் மணிக்குமார் வெல்கம்.
எஸ் சார். குட் ஈவினிங் சார். எஸ்.
டாக்டர் இளமுருகன் வெல்கம்.
எஸ் சார்.
ஜாயின் பண்ணுமா?
ப்ராப்ளமா இருக்கு சார். 2 minutes ரீஜாயின் சார். வேற ஒண்ணும் இல்ல சார்.
மற்ற ஃபேக்கல்டி எல்லாம் ஜாயின் பண்ணிட்டாங்களா ராஜேந்திரன்?
ஜாயின் பண்ணிட்டு இருக்காங்க. அவங்க எங்க ப்ரோக்ராம் வரும்போது அந்த டைம் ஜாயின் பண்ணுவாங்க. மேடம் சும்மா மேடம் உங்களுக்கு நாய்ஸ் நிறைய வருது மேடம். பாருங்க, ஏதோ பேக்ல ஏதோ சவுண்ட் வருது.
நாய்ஸ் வருதா?
ஆமா மேடம், உங்களுக்கு பயங்கர நாய்ஸ் வருது. டாக்டர் ஸ்ரீனிவாஸ் வெல்கம்.
Hi. Good evening. I just adjusting my webcam and mic. Just 1 second.
Okay.
Good evening, Srinivas sir.
Tirumurugan welcome.
சார் குட் ஈவினிங் சார். ஜஸ்ட் ஸ்விட்சிங் இல்ல சார், ஒண்ணுல சிஸ்டம் கொஞ்சம் ப்ராப்ளமா இருக்கு சார். ஒரே நிமிஷம் ஸ்விட்ச் ஆன் பண்ணி சால்வ் பண்றேன். ஜஸ்ட் 1 செகண்ட்.
திருமுருகன்
சார்.
திருமுருகன் நேத்து நைட்ல இருந்து இதே பொசிஷன்ல உட்கார்ந்துட்டு இருக்கீங்க?
இல்ல சார், எங்க வீட்ல இருந்தா பண்ண ஒழுங்கா பீஸ்ஃபுல்லா இருக்கா சார். அதனால இங்க ஓடி வந்தேன் சார்.
Very nice to see you after a long time.
Good evening sir. Good evening sir. Good evening
Ramesh Babu sir.
சார் குட் ஈவினிங்
சார்.
சார் என் வீடியோ வர்க் பண்ணல, உங்களை பார்க்கிறதுல சந்தோஷம்.
குட் ஈவினிங் மேடம். குந்தா மேடம். குட் ஈவினிங் மேம்.
குட் ஈவினிங். குட் ஈவினிங்.
ரொம்ப நாள் கழிச்சு பார்க்கறேன் மேடம். ரொம்ப சந்தோஷம்.
சந்தோஷம் சார்.
The same as much as I get to see Rajendran and others in the platform. கோபால் சார் வணக்கம். அரசர் சீராளர் சார்
வணக்கம். வணக்கம் சார். வணக்கம்.
திருமுருகனே வணக்கம். சேரனே
வணக்கம் சார். நேத்துல நம்ம ஓட்டணும் பாத்துட்டு இருக்கீங்க சார். நீங்க
என்ன சார்?
நேத்து ஈவினிங்கும் புடிச்சு என்ன ஓட்டிட்டு இருந்தீங்க. நான் எஸ்கேப் ஆயிட்டே இருந்தேன்.
அப்படியா?
தப்பிக்க முடியாது.
Srinivas Murthy is there. Hi, Srinivas.
Sir, good evening, sir. Good evening.
First speaker, sir.
Srinivas Murthy, nice seeing you after a long, long time.
Yes, sir. Yes, sir. Nice seeing you, sir.
Shall we start the meeting?
Yes, sir, we can start, sir.
Okay. Good evening to everybody. On behalf of IAP TNSA, I welcome Nanda. First, we'll start with the pediatrics in prayer by our treasurer, Dr. Gopal Subramaniam.
Respected seniors and friends, good evening to one and all. We'll start today's program with the pediatrician's prayer. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயிடன் துன்பத்திற்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவர்கள் குடும்பத்தில் இருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாத காரணத்தை ஏற்றுக்கொள்ளவும் போதுமான மெய்யரும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களும் நேரங்களையும் அனைத்து உங்களுடைய கொடுத்தார்கள். நன்றி.
Thank you, Dr. Gopal. It's respected our President, Dr. Ramesh Babu, and President, Dr. Gopal Subramaniam, and the President-elect, Dr. Suresh Balan, and the President 2021, Dr. Ismail, and AAA, Dr. Tirumurugan Sarane, and Vice President, Dr. Annamalai Vijayaragan sir, Joint Secretary, Dr. Balasubramaniam, the Editor, Dr. Dashani, and the Central as well as State TB members. On behalf of IAP TNSA, welcome one and all. So I welcome today's program convener, Dr. Tirumurugan Sarane, and who has taken a lot of effort to organize this event. I welcome Dr. Tirumurugan. And I welcome today's program chairperson, Dr. J. Kumuda from Chennai, and Dr. Arasar Sila from Chennai. And today's speakers, Dr. Srinivas Murthy, and Dr. Manikumar, and Dr. Abhiramalada, and Dr. Sendil Kumar. So on behalf of IAP TNSA, I welcome one and all. And so this is a really wonderful event. I think Dr. Tirumurugan has taken a lot of effort, and there are many topics they are going to cover with the essential for practicing pediatrician also. And this the few words I want to ask Dr. Our President, Dr. Yes,
Thank you, Dr. Rajendran. Good evening, all. Respected President 2021, Dr. Ismail, President-elect Dr. Suresh Balan, respected Secretary Dr. Rajendran, and respected Treasurer Dr. Gopal Subramaniam, respected office bearers of IAP TNSC, State and Central IAP ED members, respected convener of today's event, Dr. Tirumurugan, respected chairperson, Professor Kumuda Madam, and Professor Arasar sir, respected faculties of today's CME program, Dr. Srinivas Murthy sir, Dr. Manikumar sir, Dr. Abhiramalata, and Dr. Sendil Kumar. It's a pleasure for IAP TNSC to have you all in this today's evening CME on primary care neonatology. And this monthly CME conducted on every last Sunday of the month is one of the part of the presidential action plan. It's a great pleasure that we are all with you, and I hope that the entire pediatric fraternity of IAP, as well as the postgraduates and the students, will also be benefited of the CME. Thank you very much for the opportunity. Over to Rajendran to carry out the proceedings further. Thank you.
Thank you, Dr. Ramesh Babu. Now I welcome that's our one of the pillar of our IAP, and is beginning of our IAP success, and a tech key person, Dr. Tirumurugan Sarane, to take over as convener of this program. And so now I invite Dr. Tirumurugan Sarane.
Thank you, sir. Good evening. It gives me great pleasure to be here to organize this monthly CME on primary care neonatology. Let me just take a couple of minutes to explain to you why this topic was chosen. Neonatology generally is considered as high-end. I mean, whenever we talk about neonatology, we all talk about the most complex things. But given the sheer number of babies who are born every day, right throughout this country. I don't think primary care neonatology is given that much importance. And I must admit, actually, our president and secretary agreed with me on this aspect, and then they encouraged me to organize the CME. So that's how we zoned in on primary care neonatology as a CME for this month. And then we started wondering who are the best people to organize such a program. And then we realized actually two of the stalwarts of neonatology from Tamil Nadu, Pooda ma'am, synonymous with Gangar Mother Care and nutrition of breastfeeding of babies. And of course, Arsar sir, both of them agreed to be the chairpersons to organize this meeting to CME. So I'm very thankful to them. And we wanted to take those topics which are essential for all the people. So we are just thinking about the problems you'll be faced at a primary care setting or at best at a secondary care setting. And definitely right at the top comes breathing difficulties. And I'm very happy that my classmate, my colleague in JIPMA, Dr. Srinivas Murthy, one of the stalwarts of the respiratory support management in the country. He has done quite a few publications for management of CPAP. CPAP in meconium aspiration and other RDS babies, has agreed to talk about this particular topic. Apart from that, we have got, the other rest of the gamut of speakers, Dr. Manikumar, Dr. Senthil, and Dr. Abhiram. Everybody by themselves are big stalwarts, they won't respect. They have all agreed to talk about what is relevant to most of our babies, which we say day in and day out. So I hope that this program is useful for everyone. And without delaying any further, may I request our chairpersons to take over. Let us start with Arsar sir. He is going to be the chairperson for the first half of the CME. I'm very sure Arsar sir doesn't need any introduction. He has been the key person in ICH and currently the NNF president of NNF Tamil Nadu. So may I request sir to take over the stage, please. Thank you, sir.
Thank you, sir. Good evening, all my colleagues. My foremost, my due respects to all the senior colleagues who have joined the forum today. My thanks to the Indian Academy of Pediatric Tamil Nadu State Branch for giving me this opportunity to chair this session, and very nicely selected topics which probably would be beneficial for most practitioners of small nursing homes and corporate hospitals. And I think the speakers have been well chosen. The topics also has been well chosen. We know the first topic, the speaker, who Srinivas Murthy, is known in the field of neonatology for long. He is one of the renowned teacher, and we know his simple way of putting and explaining things to us to understand both the physics and physiology of ventilation. We know how the administration of oxygen from nasal to mechanical to gentle to HFNC. Again, now a debate on HFNC or CPAP, and the physics and the physiology has been changing. The understanding has been changing, and we have been trying to give the best to the babies. May I now invite Dr. Srinivas Murthy. He is the DM Neonatology from Chandigarh. He is presently the consultant neonatology at Paramita Children's Hospital, Hyderabad. He is, I know, very good teacher of both postgraduate teaching, and he has more than 150 research publications. And may I welcome you, sir. I'm also eager to listen to you like all the other people who have joined today in this CME program. Please take over the mics.
Thank you so much, sir, and thank you for those very kind words. At the outset, I want to thank Tirumurugan for my very colleague, friend, and my classmate from JIPMA for inviting me for the IAP of Tamil Nadu State for organizing this very important session. My apologies, I am actually in a low network, so you may not be able to see me, but I will ensure that the talk goes on well, and you'll all be able to see what I would like to address. So, Thiru, can you hear me?
Yeah, fine.
Okay.
Yeah,
Are my slides
and we can
visible?
see the slides also. Please go ahead.
Okay. Thank you so much. The objective of my talk would be to talk about why do we talk about CPAP? What is this CPAP? What are the indications? How do we titrate the knobs of CPAP? How do we monitor a baby on CPAP? When do we say that we have giving adequate respiratory support with CPAP? And when do we say we have failed on CPAP and we need to move up on the ladder for higher respiratory support? And what are the common troubleshoots and how do we address them? So these are, I'm not going to be very high end, as Thiru said that we have to talk about pediatricians who would like to manage babies on CPAP and avoid a lot of ventilator jargon. But at the same time, some basic principle will help us managing babies in the SNCUs and level 2 centers and prevent up transfers. So what is CPAP? Why do we talk about it? Because if you use CPAP judiciously, 80% of babies with respiratory support can be managed only with CPAP. So in any unit, if your requirement for CPAP is 80-20, that is 20% respiratory support with ventilation and 80% with CPAP, that means you are reasonably doing good. But if your ventilator requirement for babies with respiratory distress is more than 20%, that means you have a very good chance to improve on improving the CPAP care in the unit. So CPAP, we all know, is continuous positive airway pressure. Why is it important? Because it improves something called functional residual capacity. That is the overall lung, which is available for gas exchange during the breath cycle. And we all know that FRC, or the gas exchange, is a crux of oxygenation. And most of the neonatal diseases, except for something like severe asphyxia where brain is not working, but rest of the all respiratory causes, the cause is FRC problem. So most neonatal problems are related to FRC, whether it is RDS, TTN, pneumonia, and many other respiratory distress. And that is why CPAP has turned to be the therapy or the respiratory therapy for babies with all the respiratory problems. And earlier in the disease course, we start CPAP, better are the outcomes. We all know that if you start CPAP for babies with respiratory distress in the delivery room, the subsequent need for mechanical ventilation and also BPD in extreme preterm babies can be dramatically reduced. So it is important to talk about this topic because it decreases ventilation. You can manage many babies, you can prevent up transfers, and you can give the best outcome the baby needs. So what do you mean by CPAP? CPAP means basically we are giving 4 things for the baby. One is the pressure. Second is a blended air and oxygen mixture. Third is the flow of gases, and these flow of gases are required to deliver pressures or generate pressures. And the fourth is humidification or humidification of gases. The pressure we use in CPAP is from 4 to 8 centimeters of water. And this pressure we push into the nose, and this pressure goes into the alveoli and opens up the alveoli. So it keeps the alveoli open, thereby increases the FRC. So the pressure we use is from 4 to 8 centimeters of water. We do not use less than 4, and most people do not prefer to use more than 8, especially in babies, which all of us treat, that is from 28 weeks and above. Blended oxygen is giving FiO2 from 21 to 60%. We can give oxygen as low as 21%, that is air, or the maximum oxygen we would like to give on CPAP is up to 60%. And to generate the air oxygen mixture, we need a compressed air source, we need a compressed oxygen source and a blender. And that is when we can titrate the oxygen from 21 to 60%. And for generating pressure, we need flow of gases in the circuit. And the flow which is required for generating pressure of 4 to 8 is just 5 liters per minute. And all this gas which goes into the lungs should be warmed and humidified, because these are relatively high flow of gases. And the gases which are coming are from compressed air sources, which are cold and dry. We need to warm and humidify these gases when they're going into the nose. And that is the reason why all the gases which we use in CPAP, when they reach the nose, they should be at 37 degrees Celsius and fully moisturized with humidity. And for that, you need a good servo humidifier with a heated wire circuit. So basically, when we are giving CPAP for a baby, we're giving pressure, we're giving oxygen, and to deliver the pressures, we need flow of gases and warmth and humidification of gases. So as you can see in this figure, to generate CPAP or to give CPAP, we need a pressure generator. In a bubble CPAP, it is this bottle where you immerse the expiratory limb inside the bottle chamber or the bubble chamber, and the pressure is generated inside this chamber. And you need, for FiO2 to titrate between 21 to 60%, you need air, oxygen, and a blender, and that is required to titrate oxygen from 21 to 60%. For the vomidification, you need a good servo humidifier and with a heated wide circuit. So the gas is heated to about 40 degrees when it is coming out from the chamber and continues to get heated in the heater wire till it goes to the patient. At the patient end, it is about 37 degrees. When it goes to the nares, the temperature is maintained at 37 degrees with 100% relative humidity. So in infant 4 drivers, the pressure generator, unlike the bubble generator, is the device. This device is at the nose, which is delivering the pressures. So when do we use CPAP? CPAP basically used for 3 categories of babies. One is for babies with respiratory distress. Second, babies or premature babies with recurrent apneas. And the third condition we use CPAP is post-extubation. If you're using a CPAP for a baby with respiratory distress, that is babies who have tachypnea, retractions, and or grunt, we use CPAP when in a preterm baby, less than 35 weeks, if the Silverman-Anderson score is more than 3. So remember that babies with respiratory distress, and if the gestation is less than 35 weeks and his SAS score is more than 3, that baby needs CPAP. That is, he's telling that his FRC is less. So you need to open the lungs, improve the FRC by using pressure, and that is CPAP. If it's a late preterm or a term baby, that is if the gestation is 35 weeks and above, and if the SAS score is more than 5, then we start CPAP for such babies. And in these sort of babies who have distress and CPAP is started, we start with CPAP of 5 centimeters, FiO2 of 30%, and flow of 5 liters per minute. But if you're starting CPAP for recurrent apneas, we start with a CPAP of 4 or 5 centimeters, FiO2 ranging from 21 to 30%, and flow of 5 liters per minute. For post-extubation, that is, if the baby is removed from ventilator and want to be supported on CPAP, we start with a CPAP of 5 centimeters, and you use the same FiO2 which you use to extubate the baby. Suppose a baby is extubated 25% FiO2, we start with 25%. And if the baby is extubated 30%, you start with 30% FiO2, but the flow rate is same. So across the board, the flow rate is same. And for most of the diseases where lung is a problem, we use the pressure of 5. If there is no serious lung problem like in apneas, you use a pressure of 4. FiO2 is based on if the lung disease is there, FiO2 of 30%. If there is no lung disease, you can vary from 21 to 25%. So as I said, the most important determinant for babies with respiratory distress is to know the Silverman-Anderson score. And this score can be easily calculated by looking at the upper chest, that is the upper chest above the mid-axillary line, lower chest, retractions below the mid-axillary line, xiphoid retractions, nasal flaring, and grunting. So you can add all these 5, you get a score of 0 to 10. And if the score is more than 3 in preterms, you start CPAP. And if the score is more than 5 in preterm babies, you start CPAP. In these videos, you can see that this baby has nasal flaring. This baby also has grunt. This baby has upper chest retractions, almost like a seesaw. And you can see that there are some lower chest retractions. There is also xephisternal retractions. So this baby's score was 7 out of 10. And this baby was 28 weeker, 1 kg. So this is a candidate who is saying that he needs CPAP. He needs to work on improving the FRC. So if you want to give CPAP, you can use any one of these devices. You can use a bubble CPAP, or you can use another CPAP, which is given by Zeal company, or you can use a ventilator CPAP. And to connect these machines to the baby, you need an interface. You can use a Hudson prong, you can use a Fisher and Paykel mask, or you can use a Ram's cannula. All of them are equally good. And the interface does not matter as far as as long as the experience is improved. The more you are experienced using an interface, the better will be the respiratory outcomes and the nasal outcomes. So once you start CPAP, how do you increase the pressures? How do you titrate the FiO2 and flows? So for increasing or decreasing the pressure or CPAP pressure, you need to look at the retractions of the baby. So if the baby continues to have significant retractions, or if your SA score is same or worsening, and if the X-rays are showing low volume lung spaces, and if your saturations are less than 91%, you need to increase on pressure. So you can go from 5 to 6, 6 to 7, and very rarely you go more than 7. So increasing pressure is most of the time is based on presence of retractions or severity of retractions. The higher the retraction, the more might be the need for increasing the pressure. Now, once you increase the pressure, the retractions automatically decrease or the SI score automatically decreases. And then once this is done, then you can titrate the FiO2 to maintain your saturation between 91 to 95%. So once your retractions are minimized, if saturations are still low, that means less than 91%, you can increase an FiO2 from 30 to 35, 35 to 40, and then you can go to a maximum of 60%. So, but always try to open the lungs first by increasing the pressure, and then if saturations are still low, you increase FiO2 starting from 30 to as high as 60%. You need not change the flow parameters much, because for generating pressure of 4 to 8, a flow of 5 liters per minute is quite sufficient. Very rarely you have to increase the flows, and before increasing the flows, you need always see that there is no leaks in the circuit. But how do you know that your flows are adequate? It will be known only by looking at the bubbles in the bubble chamber. In the bubble chamber in a CPAP machine, the flow should be continuous. That means both during the inspiratory and expiratory phase of the baby, bubbles should be seen in the bubble chamber. So the titration is basically if a baby is hypoxic and has retractions, then you keep increasing the pressure from 5 to 6, 6 to 7. However, if the baby is hypoxic, that is the saturation is less than 90%, but there are no minimal or no retractions, then you increase the FiO2 to improve the hypoxia. Now, when you decrease, if the baby's saturations are consistently above 94 or 95%, and if there are no minimal or no retractions, you decrease the FiO2. Suppose the baby is on 7 pressure and FiO2 of 50%, and if the retractions are minimal, but if the saturations are above 94, 95, you start decreasing the FiO2. So you can decrease the FiO2 from 50 to 45 and from 45 to 40%. For every 10% reduction in the FiO2, you can come down on the pressure. So from 7, you come down to 6. Now from 40% FiO2, you decrease the FiO2 to 35 and 30. And from 6, you come down on the pressure to 5 centimeters. Once he is on 30% and FiO2 pressure of 3 centimeters, you subsequently decrease the FiO2 to as low as 25% or 21%, and then only you decrease the pressure from 5 to 4. So that is how you will increase and decrease the pressure and FiO2 for a baby on CPAP. Now, while you are monitoring this, you are titrating the pressures and the FiO2s, you need to monitor the baby. The most important things which you need to monitor are heart rate, respiratory rate, capillary refill time. And if you're giving slightly higher pressures than what the baby requires, the chest could be hyperinflated and the CFT could decrease because of the decreased venous return. So increased CFT is a marker of chest hyperinflation or high pressure. So keep a watch on the CFT, and it could be one of the earliest marker that your pressure is high. Silverman score you need to continually monitor, because if it is increasing, that means you are still FRC is low, you need to increase the pressure. And if Silverman score is gradually decreasing, that means your CPAP is working and you need to continue to use the same pressures. Breath sounds, you always need to auscultate on the axilla to hear for the breath sounds. If the breath sounds are heard in the axilla, that means your pressure is actually reaching the lung. Urine output needs to be monitored, because again, if pressure is high, venous return decreases and urine output could decrease. So the earliest marker of chest hyperinflation or excess pressure could be prolonged CFT and decreased urine output. Sometimes there could be an increased abdominal girth. So that is why whenever you start on CPAP, should always put a orogastric tube in place, and the tip of the tube should always be above the level of the tummy. And keep monitoring the CPAP pressure and FiO2. At the patient end, at the interface end, you need to maintain a distance between the cannula and the interface. So between the columella and the interface, there should be at least 2 mm distance. And then when you're using the CPAP prongs, the prongs should not dilate the nares. They should just snugly fit into the nose to deliver the pressure. There should not be any columella or septal damage, and there should not be any blanching on the columella or on the septae. And one needs to continuously ensure that there is nasal nares are constantly moisturized with saline or nasal drops, and always OG tube should be in place, and the tube should be open at least half an hour after feeding. In the machine end, you should always see for bubbles in the bubble chamber. Bubbles in the bubble chamber means pressure, whatever you have set, is maintained in the circuit. Bubbles heard in the chest means the pressure is reaching the lung, and bubbles in the bubble chamber means their pressure in the circuit is well maintained. Temperature should be 37. Display on the humidifier, and the tubings, the circuit tubing should always be kept below the patient level. Flow rate should be always be maintained at 5 liters per minute. Very rarely if the flow rate is requirement is increased, then that means there are some leaks and you should take care of the leaks. Never occlude the mouth of the baby to generate pressures or to decrease bubbles. We never use any passive. We can sometimes, very rarely, you need to use pacifier, but never use chin straps to occlude the mouth of the baby to generate pressures. How do we know that we are giving adequate CPAP? If the pressure is adequate, there will be minimal or no retractions. If the FiO2 is adequate, the saturations will be between 91-95%. And if the flow is adequate, there will be bubbles in the bubble chamber and bubble sounds will be heard in the chest. If the humidification is adequate, the temperature display on the humidifier will be 37 degrees and there will not be any condensation in the inspiratory limb. And if you touch the inspiratory limb, it will be warm to touch. And if you have a chest X-ray, the chest X-ray should show 6 to 8 spaces. If the chest X-ray is showing 6 to 8 spaces, FRC is adequate. That means your pressures are appropriate for that baby. Now, we have discussed to some extent how do we wean the baby from CPAP. So we take out of CPAP when the baby's pressure requirement is 4 and FiO2 requirement is 25% or less. If you're removing the baby from CPAP and if the baby is more than 1 kg, that is when the need for HFNC comes in. HFNC, high flow nasal cannula. And if the baby is less than 1 kg, we continue the baby on CPAP till the pressure requirement comes to 4 centimeters and FiO2 comes to 21%. And after removing the CPAP, if the baby has recurrent apneas, we continue to keep the baby on CPAP till another 24 to 48 hours. So sometimes you might have to keep the baby, extreme preterm babies on CPAP for weeks before you can take them out of CPAP, but they will be very comfortable on pressure of 4 and FiO2 of 21%. And if the baby is shifted to HFNC, that is babies more than 1 kg, if they are shifted to HFNC from CPAP, you start with 5 liters per minute and you maintain FiO2 of 21%. Maximum FiO2 you will deliver on HFNC is about 25 to 30%. And if the baby is maintaining saturations on FiO2 21%, you can continue to decrease the flows of HFNC from 5 to 4, 4 to 3, and then to 2. If the baby is able to maintain on a flow of 2 liters and FiO2 21%, you can switch over the baby to room air. Now, when do we say that your CPAP has not worked? You should label the baby having CPAP failure only when you optimize the delivery of CPAP. And after optimization, if the pressure requirement is more than 7 centimeters, and if the FiO2 requirement is more than 60%, that means he's not able to maintain saturations above 60%, even on FiO2 above 60%. And if he continues to have retractions on CPAP pressure of 7 or more, then you say the baby has failed CPAP. And then if the baby has failed CPAP, you can go on to nasal IMV or ventilation. Now, as I said, before you label the baby as failed or failed CPAP, you have to optimize CPAP. For that, you should ensure that there are no leaks in the circuit. How do you know that? The bubbles are seen in the bubble chamber. There are no leaks in the circuit. The bubble sound should be heard in the chest. Then only you can say that the pressure or the air is actually reaching the lungs. The humidification should be appropriate. That means there should not be any condensation in the inspiratory limb and the display temperature should be 37. The inspiratory limb should be warm to touch. The nasal interface should be optimum and it should be fitting snugly into the nose without causing excess dilatation and snubbing on the columella. The X-ray chest should show inflation of 6 to 8 spaces and ideally there should not be any pneumothorax. And still, if you want to say that CPAP is optimized and it could be a cardiac problem, then you need to get an echo. And if PPHN is there, you can optimize PPHN by using supportive care before you can say if your CPAP has failed. Some of the troubleshoots which are very common in CPAP are, there could be baby is maintaining low saturations, he's having retractions. That means the pressure is inadequate or the pressure is not reaching the lung. How do we know which of these is possible? So if the air entry is poor, but bubble sounds are heard in the or seen in the bubble chamber, that means the pressure is built in the tube, but it's not reaching the lung. This could occur if there is a nose block, or the nose block is not there, but the lung is severe and FRC is very low, or there could be a worsening of lung disease. So you need to increase the pressure, keep increasing the pressure to pressure of 7 before you can say that your things have not worked. Very rarely, if the lung disease, very often if the lung disease is showing RDS picture on the X-ray, along with CPAP, you can add on surfactant And if the FiO2 requirement is more than 30%, if the retractions are persisting, hypoxia is there, you can add on surfactant early to prevent the increased need for pressure. If the baby is hypoxic, there are no retractions, air entry is good. That means the pressure is reaching the lung and bubbling is there. But baby is hypoxic. That means the lung volume is all right. FRC is all right. But oxygenation is not good. When do you get that problem? That problem means there is a problem beyond the lung, which could be a PPHN or a heart disease, or your blender is malfunctioning. You have set 30%, but the blender is giving only 21%. So these are the reasons for hypoxia when there are no retractions and bubble sounds are seen and heard. If there is hypoxia, retractions are there, air entry is good and bubbles are not seen in the bubble chamber, definitely there is a leak in the circuit or mouth leak. If there is condensation in the inspirate limb, this means your heater wire is not working or your room temperature is low, very low. Most of these CPAPs are destined to work best if the room temperature is between 26 to 28. Or the distal part of the circuit is not under warmer. Especially the last part, if it's not under warmer, there could be a dramatic drop in the temperature before it reaches the nares, and that could lead to condensation in the inspiratory limb. You should expect some amount of dew drops or droplets in the expiratory limb. If there is no droplets or dew drops are not seen in the expiratory limb, that means your humidifier chamber is not working or there is no water in the humidifier chamber. What all we can do to improve the efficacy of CPAP or all the non-invasive modes of ventilation? For that, we need to improve the interface, whether it is mask or RAM or Hudson prongs. We need to work on one of them and keep working on them to improve the efficacy. Always, I prefer to use the bubble CPAP machine. I find it the best to monitor and also to deliver CPAP. And it's the most cost-effective machine. For a titration of FiO2, you need air, oxygen, and blender. And you need a good servo humidifier to deliver proper humidification. I would rate humidification is the 50% of CPAP. So 50% of CPAP is correct humidification. Another 50% is blended oxygen and pressure. So always ensure appropriate humidification. The gas should reach the nose at 37 with no condensation in the inspirate limb. Monitor the baby, monitor the interface and the machine to get to early troubleshoot and work on the interface or machine or the baby. Simplify the setting. Always think of pressure of 5, flow of 5 liters for most of the settings. If the pressure requirement is increasing, you can work on increasing for working on surfactant or other mechanisms rather than keep increasing the pressures. So if you're working in a level 2, you can just imagine that if you put the baby on CPAP of 5, FiO2 30% and flow of 5, most of these babies, at least 70 to 80% of babies are comfortable. But if the baby continues to have retraction, add on surfactant, and you can do LISA or MESA with the CPAP, and many more babies will come out of CPAP. Very rarely you will fail CPAP if you use pressure of 5, FiO2 30% and flow of 5, and add on surfactant early. Always know the troubleshoot where you have to work on, whether it's FiO2 or pressure, or if there is a problem, how do you address those problems? And early use of adjuvants like surfactant or caffeine have dramatically improved the outcomes of babies on CPAP. And the other thing is delivery room CPAP. Start with CPAP in the delivery room with the TPs and continue with the bubble CPAP in the NICU to get the best outcomes. If you're using too much of CPAP, definitely there is a need for backup ventilation, because I said that 15 to 20% of babies could fail CPAP, and those babies you need to work upon ventilation or have a nearby facility where you can refer if the CPAP fails. So just to summarize, CPAP is a primary respiratory support for babies with respiratory distress. Whether it is respiratory distress or recurrent apnea or post-extubation, CPAP is the gold standard now. HFNC is as its role, but I feel it is used mostly for post-CPAP. Instead of using plain nasal oxygen, you can use warm humidified oxygen with HFNC, and mostly for babies more than 1 kg. HFNC as a primary mode of respiratory support, I feel has the failure rates are very high. So I would advise using after CPAP, especially for babies who have significant FRC problems. Nasal IMV, some countries use it as a primary mode, but it is not the cost-effective way. And the training and the usage of nasal IMV is definitely much higher compared to training of the nurses for CPAP. So if you still want to learn further, please go to a preterm care package. This is available on www.pretermcareeliminatingrop.com, and you can enroll here free of cost, and you can go through the module of CPAP to learn complete basic package of CPAP. Or you can look at my YouTube videos. How do we set a machine? How do we titrate the CPAP? And other YouTube videos are available. Or you can buy a CPAP module, or you attend one of the CPAP workshop, which is commonly conducted across the country. And or you can do observership in units like JIPMER or with Tirumurugan and other people who are doing CPAP in the country. So thank you everyone for giving me this opportunity.
Thank you very much, sir. It was so, you made CPAP so simple and so lucid that I think one would gain a lot of confidence now, probably when starting a CPAP. But many times we have heard from our colleagues working in NICUs that even after CPAP, they are not seeing good results. And you rightly put it up, it's the bundle care packages of preterm that probably would give better results, not the CPAP alone, because CPAP looks at only one care, that is respiratory care. And you have rightly put it that CPAP is for respiratory support. And you need to also observe all the other packages, package of care that preterm needs if you want better survival. And if there are no questions, probably I want just ask, are there any instances where you probably can start HFNC as the first choice rather than to CPAP, and how HFNC is different from our free flow nasal oxygen?
So when you give free flow oxygen, you cannot use flow rates more than 2 liters per minute. That is going to cause a lot of condensation problems in the nose. So whenever you use HFNC, we advise that when the flow rate is more than 2 liters per minute, that is when you use HFNC. And HFNC as a primary mode can be used only for babies who require oxygen and not really the pressure. As and when babies have significant retraction, moderate to severe retractions, I think it is CPAP. And babies who do not have much of oxygen requirement and retractions are mild respiratory distress, HFNC can be used. Mostly in term or late preterm babies, and some babies with meconium aspiration, we can think of using HFNC as the primary mode.
Thank you very much, sir.
I think, Dr. Srinivas, there is a question for you. Role of sedatives in CPAP.
The best sedative is a mother's own milk. So as soon as the baby started on CPAP, we need to insert a orogastric tube and continue feeding the baby if there is no gut problem. And as long as the baby is fed well, he is unlikely to fight with the CPAP or quarrel with our machine and the interface. So most of these babies are very comfortable because they get warm and humidified oxygen and air oxygen, and also feeding, keeping the tummy well will decrease all the problems related to CPAP. No sedation and no chin strap.
Any specific care that we need to take while giving CPAP post-surfactant?
Yeah, so post-surfactant CPAP, there is nothing specific, but I would suggest that you need to wait for some time. Suppose if you're using very high pressures of 6 or 7, keep watching for prolonged circulation like prolonged CFT or decreased urine output, because these are early signs saying that the pressure is high. So you need to work on decreasing the pressure.
So because we have seen many babies after post-surfactant and CPAP develop pulmonary hemorrhages also, we feel, but we do not have objective data evidences, but personally we felt that there was more. Is there any specific reason why that problem happens?
So most of the common reasons cited for pulmonary hemorrhage is PDA. What happens is when you open the lungs, the pulmonary vascular resistance dramatically falls down, and that will open up the PDA. So you should keep a close watch on the PDA, especially in babies who are Iugr or babies who are extreme preterm. Dramatic opening of the PDA and fall in the pulmonary vascular resistance will flood the lung. So you need to keep a watch on the PDA, and if you tackle the PDA with conservative or supportive care, you can avoid pulmonary hemorrhages.
Thank you very much, sir. Are there any questions? Any other questions? Anything in the chat box?
No, sir. No further questions, sir.
Yeah, yes, sir. Shall we go on to the next topic?
Yes, sir.
Yeah, the next topic is going to be by Professor Tirumurugan. And we know this topic, focused newborn examination. I actually probably do not understand what is that focus on. And from thorough, full neonatal examination, it is just a focus one for the diagnosis that we have in our mind, or it is a well concentrated approach to a neonate. I think Tirumurugan is going to take us on this focused examination of newborn, and we would understand at the end of this what actually it means and how to proceed with this focused newborn examination. Welcome, Dr. Tirumurugan. And Tirumurugan has been one of the most active neonatologists and pediatrician, and so much involved into academics. I think it's nice to have you here today, sir, in this IAP topic on neonatology. And I welcome you, sir.
Thank you, sir. Thank you very much, sir. At the outset, I would like to thank again Dr. Ramesh Babu and Dr. Rajendran for allowing me to talk about a topic which, as sir said, not a lot of people understand. It's often neglected. See, us as undergraduates, we get taught a lot about a lot of examination, whether it be cardiovascular, respiratory. They are all the heartthrobs, isn't it? When we get excited about hearing the murmurs and various sounds or looking at the abdomen. And of course, the king of all, the neurological system. Usually in pediatric postings, we get 1 or 2 sessions on newborn examination. And even then, it's more about neonatal reflexes because everything else is irrelevant. Or it gets kind of pushed lower down in the pecking order. Now, but when we come to real life, what happens is this. I just want a couple of you to just answer, drop in the chat box your opinion about this. What do you see? I mean, what do you just see? If you can just put it in the thing just for the next 10 seconds.
We see newborn baby.
Sir.
With the face, hand, and also the legs. Okay, and also a couple looking at Tirumurugan's
beautiful lake. Yes, sir. So it depends upon what we want to see. I mean, you could see this natural, you can see the trees, and you can see the couple, and you can see the lake, or you can, of course, see the newborn baby. And that's what happens when we talk about a neonatal examination, because whenever we are taught about the newborn examination, it's overwhelming, and there are a lot of things to look at. And unfortunately, when we really do in life, we often get called in a resuscitation scenario, particularly after in the cesarean section, and then where we are told to say the baby is all right, and can we go ahead with the sterilization. I mean, it's one of the most difficult jobs for any person, a neonatologist or pediatrician, to say the baby is normal or not abnormal. And probably that's one area where, and we have got hardly even few minutes. By the time the obstetrician finishes off the uterine switches, she wants to tell us if the baby is okay or not. And so that's probably one area where we need to stick with our newborn examination, try to come to a conclusion within a matter of a couple of minutes. And the next one we need to do is within 24 hours. Imagine most of our places, particularly in the many places where they're delivering easily 10-15 babies in a day, and trying to examine each and every one of them in the detailed manner, it takes forever. So within the very limited time available, we need to somehow come to a conclusion if the baby is okay or not. And of course, again, prior to discharge. So we need to make sure that the baby is fit enough to go home and there are no obvious danger signs, so that we don't want the mother to bring back a baby who is sick or even dead. So these are 3 probable instances where we could think of newborn examination in a focused manner, where we need to, it's more about being up to the point rather than looking at everything. So what are the prerequisites for examining a baby? First and the most important, there are triple E's. So let me start with the first E, which is environment. We basically need a warm room. A baby who is in a cold room with a nice AC on is just going to scream down the place, and we are not going to get findings very well. Obviously, the room has to be very well lit, preferably natural light. If not, at least even with artificial lighting, a good well lit natural light, white light is very important. Again, we don't want everyone screaming because we will not be able to complete our examination properly. And last but not the least is that the environment where the baby is placed should be warm. So the next bit is what are the things which we need? Definitely we need a watch with seconds to observe the respiration heart rate. We need a good stethoscope. I still remember the times when our professor Dr. Srinivasan used to force us to buy a Litman, without which we couldn't enter the pediatric ward. And the ophthalmoscope, of course. We need a good ophthalmoscope. I just wonder how many of us really carry one, and a good torchlight. But last but not the least would be ourselves as examiners. If you really look at it, we need to think about having at least 3 to 5 minutes for examining a newborn baby. And that's a bare minimum we really need to examine the baby. And we should be prepared to have a proper hand hygiene. Even if we cannot wash hands with each baby, at least we should be able to willing to use a alcohol rub. So once we are ready, we will go about examining the babies based on certain basic principles. It's not like inspection, palpation, or percussion, or auscultation like older babies. It's a little bit different. And no history is relevant, no examination is relevant unless we have a proper history. Now, given that over the years, what I've learned is, yes, it's important to ask, but what is more important is to check the records. Okay, yes, you talk to the mother, you find out, you can talk to the obstetric colleagues and then find out, but there are innumerable times when we have been stumped when we looked at the records. So never forget to go through the case sheet before you actually touch the baby. And when we look at the examination itself, we have to look at, we need to follow these 3 dictums. Always look, listen a little bit, and feel even lesser. Now, this is different from what we are always taught, but this is going to be more productive if you follow this. So let's start with examining the baby soon after birth. What is my objective when I do this? All I care about is to find out if the child has got any critical or disconcerting anomaly. I need to make sure that the baby's cardiopulmonary status is okay and there are no major congenital malformations. It's really worse if we miss, let's say, a major anomaly like a cleft palate or a genital abnormality or let us say analepsia. Say everything is okay, come back after an hour to find that the baby is having all these problems, and then we cutting a sorry figure. All the points which we are going to look at in a newborn, the importance of which varies based on the gestation age. So it's very important to have an accurate gestation age. And always remember about whether the baby is appropriate for gestation, large for gestation, or small for gestation. Now, very often we come across another terminology called as Iugr, or nowadays moved on as fetal growth restriction. Now, please remember that fetal growth restriction and SGAs are not the same. Fetal growth restriction basically means that we have got a baby who is less than optimal, who has had less than optimal growth intrauterine over a period of time. So you could have small babies who are not fetal growth restricted, or vice versa. You could have normal appropriate size babies who are fetal growth restricted. So what would I like to ask in the history? Yes, there's a huge list we can ask, but probably these are the bare minimum which I personally would like to ask. One would be, is the mother's maternal, is she a diabetic or not? What about the Iugr status? That's going to give me a lot of information. What is the maternal age? Of course, older the mother, the more likely to problems in the babies. And what is the presentation? Like if you can have a baby with breech, you might have, they are more likely to have a dislocation of hip and so on and so forth. So probably these are the bare minimum history I would like to know beyond within the available time. So once the baby is stable enough, I've resisted, these are the things I would like to look at. Always look at the heart rate. Now, we are all taught in our NRP programs to concentrate a lot on bradycardias. So whenever the heart rate is less than 100, we want to support the respiration. When it's less than 60, we want to support the cardiac status. But what we don't remember very often is that tachycardia is as much important as bradycardia. So if a baby is going to have sustained tachycardia, look for a reason, and very often it is respiratory. So the baby might have some grunting or might have some difficulty in breathing, and along with that you get a tachycardia, or maybe it's in a bit of early shock, and which we can easily miss. So do not forget the tachycardia. Of course, we need to look at the respiratory effort, and as Dr. Srinivas said, we can look at Silverman score as a useful measure, or there are very simple ways of doing it, which we'll look at in the coming slides. Now, most of us are taught to look at color. I mean, we are told as RHC, so as color. But what we need to realize is that our eyes lie. Our eyes are just not good enough to figure out if the child is hypoxic or not. In fact, if you remember, a baby looks pink even once the saturation is above 85%. So if you really want to identify a baby who is hypoxic, we need a pulse oximeter. And the ideal pulse oximeter is the one which has got a signal extraction technology. The digital technology very often is not very accurate in picking up the saturation. Now, if you are in a situation where you don't have a pulse oximeter, another useful measure is a tone. I would probably even say this as a poor man's monitor for the cardiovascular status. So a baby who has got a good flex tone, who is pink, who is having normal respiration and normal heart rate, is definitely having a normal cardiovascular stability. And of course, how he is reacting. Okay, let it be a cry, let it be sneezing, let it be a response to a suction catheter, all this matters. So all of this you could just do by having a basic look and making sure that the baby is fit enough for undergoing further examination. Okay, so we are taking care of the primary most important to make sure the baby is alive and well, and then now let's move on. So what are things I will look at? This is all about a quick screening for malformations. I'm not going to do a detailed examination. So basically I start from the top to bottom, midline to the back. So what do I start? I will start with the head, look for any obvious dysmorphic features. Again, I will talk about in detail in the subsequent slides. Look for asymmetry of movements of the face. You can, particularly if the baby has undergone an instrumental or forceps delivery. Now, very often we want to check for esophageal patency. So what do? We tend to put a nasogastric tube or orogastric tube, and then make sure that there is esophageal patency. This is a practice which probably has to be abandoned for multiple reasons. The most important reason is that we can injure the esophagus or the stomach. That's number one. Number two is that very often the catheters can coil within the dilated esophagus, and it will appear as though we have got a patent esophagus. In reality, it's not the case. So what else we can do? All we can do is to look for pooling of secretions. If you remember, all the fluid is coming out of the lung. Part of it gets absorbed, but there's a huge amount is still coming out of the lung into the oropharynx. And that has to be absorbed through they go down the GIT. And if there is a block somewhere down there, it is going to get pooled. So if you get a lot of excessive pooling of secretions, then we need to think about a esophageal atresia. Now, cleft palate is something which is often missed. Now, the best way to look for is, again, there is a lot of debate, but you can easily look into it and see there is cleft. But if in the case of submucous cleft, the only way to figure out is to feel the palate and then find if there is a cleft palate or not. Now, looking into the eyes is a bit difficult soon after birth because the babies tend to close their eyes quite a bit. And but it is important, particularly in the scenario where we need to go ahead for a sterilization. And of course, ears are something which is fairly obvious. We are going to look at and then see if there is deformity. The next bit we need to look at. So we have finished the head, come to the chest, look at if there is any obvious signs of increased work of breathing, that is chest retractions, flaring, or increased work of alanising. And then we go down and then look at the abdomen. And there is one anomaly which we can miss all through our life. We don't figure out right after delivery, that is the single umbilical artery. Given that nowadays a lot of mothers have very good ultrasounds antenatally, it is quite which picks up a lot of congenital anomalies. Probably is of less importance, but it's still useful. Finding to pick up. Now we talked about esophageal atresia. The next one I would look at would be the anal atresia, the anorectal malformations. Please remember, when we are looking at the anal opening, we need to just not look at only the opening, but also where it is located. Now, very often we are happy to stick a catheter and then look for and then claim that the anus is patent. It is a practice which should not be done because most cases of anorectal anomalies can just be obvious just by looking at it. And sticking up a catheter is more likely to cause a rectal perforation than to establish clearly the absence or presence of a anal atresia. Last but not the least is looking at the genitalia in the abdomen. This I'm talking about the abdominal examination. This is something we have to be very careful, and let's not be in a haste to assign a sex for the baby. If we are not sure, it is better to take some time and declare later on rather than other way around, because that's one which gives a lot of problems. And then move on to the limbs. I said top to bottom and then front to back. So look for the asymmetry and look for any obvious anomalies. It's not going to take much time. And again, when you look at the back, look for spina bifida. All this looks very simple and intuitive, but the problem is that over the years, definitely we have come across a lot of patients who are missed findings. I've seen babies at 2 months with a large cleft being missed. I've seen babies with at 1 year with the spina bifida being missed, and so on. So keep that in mind. So having looked at the baby, then let's learn to listen for the baby. So listen to the cry. If the cry is vigorous and happy, I'm very happy. If the cry is weak, I'm worried, and definitely if it's hoarse, I'm not at all happy. And look for abnormal sounds, particularly grunting. And finally, get a stethoscope and listen to the heart sounds. Instead of looking for murmurs are probably not important, but they don't give a lot of information the first 24 to 48 hours. But it's more important to listen to which side it's heard, better on the right or the left side. Again, my teacher has really emphasized this important on me as a student. So yes, I need to. And then move on to feel. Okay, there is a little mnemonic if you want, you can remember. But what are things you need to feel? You need to feel about 7 things and nothing else. Most important is the femoral pulse. One of the pulses which are just not given due importance, but it can give you so much information. A weak pulse, think of heart disease, think of shock. It is very, very important. And then look for a capillary refill time, again to suggest how well this child is perfusing. And never to forget to palpate the abdomen in a newborn period. I mean, soon after the birth. So you can always miss a big tumor or a renal mass and then find it difficult to explain later on. Genitalia, yes, not only look, but also feel, particularly for the testes in a male baby, to make sure that it is descended. And another point, another atresia, which everybody likes, is the coronal atresia. We again like to put a tube down the nose and then look for. But please remember, a coronal atresia, a unilateral coronal atresia, we will not pick it up by just putting a tube down the nose. And bilateral coronal atresia is easily picked up with the pulse oximeter. If the baby closes the mouth, the baby is going to, saturations are going to drop. If he's going to be screaming, the saturation is going to be normal. So easy way to pick up rather than trying to put a tube in both the noses. Last but not the least, hip dislocation. Usually I don't do it, I must admit, but it is something worthwhile doing because it's a major condition to be diagnosed soon after birth. Once we have done all this, just make sure that any other finding which we have picked up on inspection, confirm it, and then we can go about and then see. Just a couple of words about pulse oximetry. See, in the ideal world, we like one of these, the signal extraction technology pulse oximeters. I mean, right now it's mainly the proprietary with Massimo, but expensive. Right now it's close to 70,000-80,000. So there is another option which is Indian made by the IIT Chennai along with this startup from IIT, which is worth trying. So let's go on. This costs less than 7,000 and it's quite useful, can be used in a neonatal period. And as you can see, we are just using it on newborn. and it's fairly accurate. In fact, I've compared it with both. So it's something which you can consider, made by the company Elixir, but it's an IIT Madras startup. So moving on. And that's at the end of this, you can say if the baby is okay or not. You can say if there's any obvious life-threatening or gross anomalies or not, and then move on. And then once we have done that, we always come back after about 24 hours and then re-examine the baby. Now, the objective of this is to say if the baby is normal or abnormal. Again, going back on the history, we have already, whatever we did in the first set, we need to look at again. But there are a couple more we need to look at. But one is to ask the mother about the activity of the baby. Ask her if the baby is crying, if the baby is feeding, has he passed meconium, has he passed urine, and are there any other problems she would like to report. And that is something which is very useful. And then again, check. Never to forget to check the gestational age, the weight of the baby, how much weight loss has been there, and what is the temperature. Summer babies get too hot, winter babies get too cold. And the worst is in summer babies do get cold, particularly they are in the AC room. And the same stuff about looking at the cardiovascular stability, whatever we have discussed, and then move on. See, early on when soon after birth, we just screened through. We didn't spend a lot of time because our time was limited. But here we spend a bit more time, look at carefully, but really examine the baby from top to bottom. So the first thing we need to look, it's all about look. Please remember, look is far more important than listen, which is far more important than feel. So start with the skin color. If the baby is pink, maybe with the blue peripheries, that's fine. I mean, you can have acrocyanosis, it's very much physiological and normal. If the baby looks pale, it could mean that baby is in shock or is in anemic. Yellow babies, particularly within first 24 hours, is always a danger sign, and we have trouble. If the baby looks a bit cyanosed or with blue, obviously cyanosis, again something to worry about. So that one single finding is going to govern everything else. We don't need to go through the whole lot like a long case and then come back to say this child is having a problem. Of course, there are going to be focal changes in the skin or discoloration. Some of them are physiological, some of them are pathological, but self-resolving, and some of them are definitely pathological. Okay, so looking at it, we can have something like a milia, few changes, peripheral cyanosis, like you can see the cyanosis around the nose, and sometimes even petechiae. Very often neonates can, though it can be abnormal, we can very often it's normal, particularly in babies who are born vaginally. You can have a major bruising. Yes, it's a pathological finding, but it will resolve over a few days' time. Peeling of skin is another physiological finding, or of forceps bruising. So once we have looked at the skin and made sure we are happy with it, we move on and look at the posture of the baby. Okay, and all we need to look at is his movements are symmetrical or not, if there is good flexion at the upper and the lower limbs. And again, it is to be correlated with the gestational age. Presence of cortical thumb at any age is abnormal. And if there is asymmetry, either of the face or of the limbs, we need to be worried about. And having looked at the color, I've looked at the posture, I've just moved on to the head. Okay. So look at, very often you might see a bit of molding. Others are worried. You just need to, so you can see here that it's basically one bone sitting on top of the other. You can see the ridge, and that is fine. Or sometimes you might see a caput as well, diffuse swelling. We are happy with it. And sometimes this might be capsulohematoma. I'll come to how to differentiate with the two in the field. Now, I promise that we'll discuss a little bit more about how to look for dysmorphic features. Again, something which we are repeatedly taught, look for dysmorphic features. Or we assume that, okay, it looks like a Down syndrome, or it looks like one of the other syndromes. That's what we look at. So what are things we need to look at? There are 7 different points we need to look at. One is to look at the orbital placement. See how close or how far the orbits are. Second is, what is the palpable fissure length? Okay, is it too narrow or too big? Again, there are criteria for this, but for most of us, we can look at it and then we can think, is it too small or too big? And then what is the slant of the palpable fissure? And are there any epicanthal folds or not? If there is any, sorry, got mixed up. If there are any midfacial acroplasia, in other words, it's going to be a flat, depressed nasal bridge. Okay, what is the shape of the philtrum? And finally, what is the ear placement? Do we have low set ears or normal ears? Once we have done that, get the baby to open the mouth. All we need to do is just put the finger on the upper or lower lip, and they will happily open the mouth. And you can see, very often see a natal teeth. Sometimes you can see a cleft, which can easily be visualized with a torch. And always look for a tongue tie, not because they create a problem, but it causes a lot of anxiety. Unless it's really one of those grade 4 tongue ties just stuck to the base of the floor of the tongue, floor. Most tongue ties don't create trouble. And then look at the neck, see for any excess well-being or goiter. I've never seen one in the life. And then look for the increased work of breathing. So you can look for 3 things: a tachypnic baby, a baby with severe chest retractions, and you can, as you can see, the head bobbing, and then the alar nasal flare. And then move down to the abdomen. Look for any obvious scaphoid abdomen or a distended abdomen, or sometimes you might see a gastric abdominal wall defect. That's all. I only care about findings which are going to tell me if the baby is going to be normal or abnormal. It's very important to examine the look at the genitalia cavity and try to decide is it male or female genitalia, and there are any obvious problems with it. And as said, anal patency is fairly easy to look at. All you need to do is look at the presence of, in any case with anal anorectal malformation, you will not find the anorectal sphincter. The absence of an anal sphincter itself would suggest to us that the anal patency is just not there. And then come to the peripheries, look at the limbs again, see if there is any asymmetry or if there is any abnormalities, particularly if there is any polydactyly or syndactyly or any fractures. And then go back to the back to look for the spina bifida or any swelling or any tufts of hair or those. So now I have looked at the baby, and now I will move on to listen to the baby. Again, listen to the cry. Such a wonderful way for the baby to tell us that they are all right or they're not all right. Grunting and heart sounds. Now, apart from this, at this juncture, I would like to hear about the murmur also. But please remember, when we listen, most murmurs are a very, very common finding in a neonate. There are a lot of reasons why we have a murmur, but very rarely they're associated with this significant heart. In fact, most critical heart diseases are rarely associated with the murmur. So murmurs, though they are exciting and alarming, they rarely are as important as your cardiac pulmonary stability, your femorals, or your work of breathing. So keep that in mind while listening for a murmur. So we look for and then we move on to feel the baby. So we have just looked at it, and now we just want to feel the baby. Again, we can feel the molding, feel the anterior fontanel, posterior fontanel. And then if you get a swelling, how will you differentiate between a caput and capillary? All you need to do is try to depress the swelling, and then just see. If the swelling is clearly depressed and it does not refill immediately, it's a caput. If not, it's a capillary. And then move on. So whatever we told right in the initial examination was good, except we have added one more, which is jaundice. Okay. Now, how will we look for jaundice? Always try to look for the jaundice in the clear light, so a well-lit place, and with the skin blanched. It's really important to look for the jaundice only when the skin is blanched. Otherwise, it's very difficult to look for a yellowish discoloration, particularly in our Indian babies who are dark colored. And then femorals, never ever forget femorals. You get some fantastic diagnosis just by feeding the femorals. Capillary refill time, once again, abdomen, genitalia, and in a genitalia, always feel for the testes. I mean, it's so sad to find so many boys, undescended testes in the boys being missed. They're coming at 2 years, 3 years with undescended testes when already the damage has happened. As said, colon atresia, think of pulse oximeter, and last but not the least is hip dislocation. So for the hip dislocation, couple of words. So we got 2 tests to do. One is a Barlow's test, which basically looks at the ability by us to dislocate the hip. So, and always remember that you need to do only one side at a time and not both sides, because then if we try to do it both the sides, we can break the femur. And the other one is orthodontist, which is testing for the ability for the dislocated hip to be relocated. And next is, as said, most of us don't carry a ophthalmoscope. So, but at least we can carry a torch, open the eyes, and then just see. This was a baby who was just born with us. I mean, he landed up having a congenital glaucoma. All we had to do is just open his eyes to see that he's got severe corneal clouding at birth. So, and even cataracts can easily be seen if you can shine the torch at an angle and not right at the eye directly. At 90 degrees, if you shine, you will not see it. But at a 45 degrees or even at 30 degrees, you can even identify a cataract. But the ideal way of doing is to look at the red reflex through an ophthalmoscope. So what we basically need is a reflex which is bright red, and anything except red is not acceptable. Always then move on to feel the clavicle and the humerus. Okay, very often we get missed clavicular fracture, particularly with the difficult delivery. Last one, which I probably do, would be the Morris reflex. This probably might be the only reflex I like to do among all the gamut of neonatal reflexes. Just on in my focused examination. So I have done all this, and then I have decided that my baby is okay, everything is all right, and is it okay to let go the baby and not come back and have a look at him? And the answer is no. Always remember that just before the baby goes, we need to do a discharge examination. And this is the objective of this is to make sure that there are no danger signs. The baby is fit and ready to go home. Again, history, same stuff. And then cardiopulmonary stability. And the other couple of things we need to look at is there any obvious discharge from the eye, if there is any discharge from the umbilicus. We don't want to miss umbilical sepsis on baby coming back with the major septicemia. And then the one thing I will always like to listen is to look for the auscultate the heart again for a new sudden appearance of a murmur. In which case we can do a hyperoxia test and we can just do a pulse oximeter screening and then find out if the baby is okay or not. And then you feel temperature always by touch. I mean, you can always record it, but if not, at least by touch. And then depth or the extent of jaundice, and confirm any other findings which we have seen. Again, I keep telling about pulse oximeter again and again. So when we look at, it's all about what we want. It's not about trying to do every possible finding in newborn examination. I'm sure there are umpteen number of findings which you'll find out with every newborn baby, and some of which just cause a lot of anxiety. But the idea of a focused neonatal examination is really to find out if the baby can be in significant trouble, or the baby is normal, or does he have any danger signs at all. And that's all it's about. And given that we have to accept the reality that we are extremely busy, we will not land up examining 30 babies perfectly. So let's find out what needs to be found out and make sure that every baby is okay. So it's all about focusing. If you can, again, there are a lot of babies here, or maybe there is a tree. I just want you to find out the number of babies in this picture, and then again try to put it. So if you're good enough, you'll probably pick up at least nine babies. So it's just about how we focus, and then it's about having a clear objective. So thank you very much for this opportunity and for the patience listening. Thank you.
Thank you, Professor Tirumurugan. It was wonderful. I now understood focused newborn examination is all about a very comprehensive examination, that we do not miss anything in the baby, and ensuring that it is safe to go home with all things needed. But the way I understood before you started the topic was focused newborn thing, because in our SNCU, probably there are many times where simple focused, I will tell you the way I understood, I thought that the talk would go on. A child who comes with not passing stools, the postgraduate sends it back, on duty sends it back saying, it's still not 24 hours, come back if more than 24 hours not pass stool. The next day it comes back and we do an examination, we see there is no ANS. So it's an absent ANS. And here, a simple examination before sending it back to the postnet ward would have been to look at the ANS, whether the anal orifice is there, and probably then sending back to ask them to wait for 24 hours. A baby that has come with not voided urine, simply not telling it wait for 48 hours, but you just feel the bladder and see in a male baby whether the bladder is distended to rule out a posturethral valve. So I think the way I probably thought focused way, another way of looking at things, problem-oriented focus, what you actually need to look at. But you have put up a very nice comprehensive neonatal examination with lot of nice illustrations. Thank you very much. It was very nice. If there are any questions from the audience?
So Srinivasan sir wanted to say something. I think he raised his hand. Sir?
Yes, sir.
So Srinivasan sir, he wanted to say something. I think.
Sir, Srinivasan sir, you wanted to ask one question?
No, he wanted to say something.
Dr. Srinivasan, you're on the line?
No, sir, looks like we have missed him. Actually, he was there. I don't know. Maybe I think he's rejoined. Terila sir. Okay.
Okay, so a thorough examination. We have been insisted on how important it is to do a thorough clinical examination because it is the responsibility of the treating physician or the neonatologist before sending them home as a well baby, that we ensure that we probably have checked everything and the baby would be safe at home. And I have had instances where baby had been sent home and coming back later to the well baby clinic saying the child is passing stools through the vagina, where we have missed a rectovaginal fistula. Many times it has happened, we have missed tracheostomy fistula, sent to postnatal wards. There for 2 days, told by our postgraduates and rounds that correct the feeding technique, and finally on 3rd day diagnosing tracheostomy fistulas. And I think these are some of the pitfalls. I think that one must try to learn from experience, that one should do a focused, thorough, comprehensive clinical examination when a baby is brought for any complaints. I think we need to make ourselves absolutely sure we are putting there when you are writing it's a well baby, that we have looked at everything. Thank you, Tirumurugan.
Thank you, sir. Thank you, sir. Actually, no, sir. What I taught is basically what a newborn examination is done, at least in UK where I have been there. So it's far more comprehensive. It basically does not miss out any major anomalies, and that's what this is about and nothing else. So thank you very much for the opportunity, and thank you, sir.
Thank you very much, sir. Shall we move on to the next topic?
Yes, sir.
Yeah, Dr. Manikumar, welcome. And all of you know Dr. Manikumar. Dr. Manikumar was the academic coordinator for NNF till last month, and he is just given that responsibility now to Dr. Shobna. And one of these very soft-spoken, very patient, very learned person, but still very soft-spoken. And I think Manikumar is a good teacher. He has helped me a lot of times in preparing topics for postgraduates. May I now welcome Dr. Manikumar to start his FAQs on neonatal jaundice. I think definitely he should have put up a lot of questions. I think a lot of more questions also will crop up for this topic. Welcome, Dr. Manikumar.
Yes, sir. Thank you, sir. Yeah, good evening, everyone. And first of all, I would like to thank the organizers for giving me this opportunity to deliver this talk. And the coming 25 minutes or so, I'll be dealing about the frequently asked questions in neonatal jaundice. So jaundice, literally everyone will be treating neonatal jaundice. And my overview is to cover the simple physiological aspects with the common etiologies and the recent NNF guidelines which have changed some of the recommendations regarding screening, phototherapy, and other alternative therapies, and a brief note about cholestatic jaundice. So this is going to be my overview, and I hope my slides are visible clearly, sir. Yeah. I think my slides are visible, right?
Yes, sir. You are audible and your slides are visible.
Yeah, thank you, sir. Yeah. So coming to the physiological aspects, we all know that bilirubin is formed from hemoglobin. So the heme gets converted to biliverdin. I would just like to stress upon only one point here. the step where biliverdin is converted to bilirubin is very unique to humans. It is an energy dependent step which is inherited through the generations actually. So because all the birds will excrete it as biliverdin. So the stools of birds are green in color, and we only pass yellow stools because we use some energy to convert it to bilirubin. All I want to say is that bilirubin is beneficial. It is an antioxidant. So this energy dependent step is evolutionarily preserved to have a survival advantage basically. So bilirubin, some amount of bilirubin is good for health. So that is one thing which I want to stress upon. We'll come to that later on how it is applied clinically. And after being liberated, it gets bound to albumin in the circulation, and it enters the liver through ligandin and gets converted to conjugated bilirubin and gets excreted through the transporters, the multidrug-resistant protein 2 and 3, to the gut, where it is converted to urobilinogen or stercobilinogen and is excreted through the urine or stools. So this step is also important as the excretion is both through stools and urine. And all those stars indicate where the newborn is deficient at. There can be some increased production, deficiency of ligandin, decreased enzyme deficiency. So all these will contribute to the high risk of jaundice in the newborn period. So literally all babies develop some amount of jaundice. So how do we define jaundice is that we typically use the specific nomogram. Previously, they say that more than 15, we call it as hyperbilirubinemia. The strict definition will be more than 95th centile for on the specific Botany nomogram. In more than 35 weeks, preterm babies, it's not clearly defined actually. So why do we worry? Because any jaundice, however high it is, even if left untreated, will settle on its own after some point of time. Even if you treat it or not, it will reach a peak and it will come back to baseline after some point of time. But till then, there is some increased risk of bilirubin-induced neurological dysfunction because bilirubin crosses the bilirubin barrier and it affects the brain tissues. So there can be some acute manifestations which we call as acute bilirubin encephalopathy, or there may be some chronic manifestations or a permanent sequelae which we call it as the connector spectrum disorders. So these connector spectrum disorders typically include a choriostatic CP and some dental dysplasia, gaze palsies. So these are the hearing defects. Hearing defects are the commonest things which we see in the long term. So these will be the concerns why we have to treat neonatal jaundice beyond a particular level. So how are we to find these acute bilirubin encephalopathy? We have what is called as a bind score. So this bind score, it typically based on 3 parameters: mental status, your neuromotor tone, and your cry. So basically these 3 parameters reflect where the bilirubin is getting commonly deposited in the brain, where it can go to the cortex and affect the mental status, where it can affect the basal ganglia and affect the tone, and where it affects the brainstem and can affect the cry. So this modified bind score will also include a brainstem evoked response autometry or automated auditory brainstem response. So by this, early encephalopathy is reversible completely. So it's very vital to identify that at the early stage. But it's very late, it is mostly irreversible actually. So this is the typical oppositonic posture which we want to avoid. We should not see such a baby hereafter. That should be our aim basically. So what are the common etiologies? Why should we know about this? Because these literally the common things are relatively common. First thing, whenever there is the onset of jaundice less than 24 hours, we always think of hemolytic disease. The common things would be RH, ABO, and if it is not there, even a minor blood group incompatibility is the next common thing which we see actually. And if the onset is in the typical range of 24 to 72 hours, it's the typical physiologic jaundice. And it could all the other pathologic variants could be something like a cephalometoma or a breastfeeding jaundice is the very common cause. So here I would like to stress upon this breastfeeding jaundice because what is more important in identifying this cause as the reason for your jaundice is that it's just a manifestation of some other problem. Here the main problem is inadequate breastfeeding. And it's like giving paracetamol for fever. Fever is because of some other illness. We just give paracetamol and we can't expect the fever to settle down on its own. So something like that. It's breastfeeding jaundice. The problem is poor feeding. Jaundice is one of the manifestations. By just putting phototherapy, we can't treat it. We have to correct the underlying issue of poor feeding. That is the most important thing that we have to do. So that is just a manifestation. Keep that in the back of your mind actually while treating. And if onset is beyond that, still some amount of breastfeeding jaundice has its onset in 72 to 7 days actually. And especially if it goes after some 10 to 14 days, we think of breast milk jaundice, hypothyroidism, and some other partial intestinal obstruction, or even pyloric stenosis can manifest like this actually. Yeah. So how are we to identify this? So now we have what is called as the we do follow this Kramer's rule. Sorry, we do follow this Kramer's rule for a longer time. So he described typically 5 zones with varying levels of jaundice. And but the problem is that though this is the only assessment which is done in most of the SNCUs, as I could see, still it requires some experience, or rather I will call it as a local experience, because many of those SNCUs are ill-lit, so that it might be very difficult to assess. So it requires some time to adapt to your particular area to find whether there is having some jaundice or not. So always get some fresh sunlight, which is very abundant in our place. So the SNCUs are designed in such a way that there should be some fresh light entering the SNCU. So the studies, even in light-skinned individuals, consistently show a correlation coefficient of 0.35 to 0.75, meaning it's a weak to moderate level of correlation only. And in fact, the one of the authoritative speakers in bilirubin metabolism, Dr. Meisels himself has told in a lecture that bilirubin eyes do not exist. So it is neither objective nor reliable or accurate. Nearly 60% of newborn infants in a study are misclassified. One will say it is zone 3 and another person will say it is zone 4. The inter-observer reliability is very poor actually. So what are the other screening methods? And traditionally what we call as the Engramming Parameters. Just it's a slide-like thing, transparent slide, which we have to press in the nose and compare with the color, which is best. So those are one thing. And nowadays, I think this Bilicam is going to be the future actually. And previously, it is very complicated where we have to attach a camera to a cell phone. But nowadays, most of the cell phones, high-end cameras, they are inbuilt in that. And the future is going to be that actually. You just have to place some color cards over the baby for comparison and just take a picture, and that will give the amount of bilirubin. Still, this is investigation right now. So what is being used even in most of the SNCUs is the transcutaneous bilirubin monitoring. So this dragger JM103 is being supplied to most of the SNCUs. And these typical transcutaneous bilirubinometers have some algorithm to correct for the closely related pigments, which include hemoglobin also. So here in JM103 by Drager, they use a short optical path and long optical path to take care of melanin. And so there are some algorithms to look for that. And this correlation coefficient is very high, literally 0.7 to 0.97 for screening. And the only disadvantage is that it can't read about 20, it becomes unreliable actually. And in the normal range, it's usually reliable. And the NNF gave a clear recommendation that transcutaneous bilirubin may be used to screen in term and preterm neonates. And if values fall within 3 milligrams per deciliter above or below, roughly 3 to 0.9, we have to check with the serum bilirubin. So this takes care of most of the time, whether you want to prick the baby or not to look for a bilirubin. So this has to be done routinely for all babies, and that's what is recommended actually in Western setup. At least where it is available, you can use that definitely. Only disadvantage is that it becomes unreliable during phototherapy. Now the reliability becomes up to 0.47, which is really something like weak to moderate. So during phototherapy, ideally total serum bilirubin is preferred over transcutaneous bilirubin. That is what the NNF recommendation is. And we all know about phototherapy. I no need to tell about that. And that is a gene sister word, while a sister's observation changed literally the aspect of how we treat babies of jaundice. So literally that simple observation where the sunlight has gone, and while changing the diaper, she noticed that the inside skin inside the diaper is yellow and all other areas are bleached. So that observation literally changed literally. And even now we have no other better treatment for jaundice other than this phototherapy, and X-ray transfusion is the next thing. So other than these two therapies, we don't have literally anything to supersede all these things. So it uses a specific light spectrum in the visible blue. It's not ultraviolet actually, non-visible. So it's in the visible spectrum in 460 to 490 nanometers. There are two main pathways which we convert. So one is a structural isomerization to lumirubin, and another is a configurational isomerization to the ZT components. So the whole important thing here is that I want to stress upon is that ultimately after conversion, all these isomers are excreted either through the bile or in the urine. So it's very essential that the baby should pass stools or urine, and for that feeding is very, very essential. So don't try to stop feeds for want of phototherapy. Some people will say that your bilirubin is very high, don't take the baby and feed for a long time. If 50% is by phototherapy, the remaining 50% is by feeding. So don't try to stop it literally. So don't hasten the process. Effectiveness of phototherapy depends upon various other factors like the initial serum concentration of bilirubin and the area exposed, the distance between the light source and patient. It has to be as slow as possible, by which we mean nowadays all licensees have the LED phototherapies, and thanks to Nodal Assist Srinivasan sir and Kumda ma'am and VVK sir. So they have ensured that we have the highest quality phototherapy machines in all licensees. So we can reduce the light source as low as possible without causing any hyperthermia actually. So usually around even up to 10 to 15 centimeters is perfectly fine, but not below that, because the surface area will be reduced, because the light is not a homogeneous light, it's a small light, and the surface area will be reduced if you reduce the distance too much. And there is no saturation point with the irradiation dose. If you increase the irradiation dose, there is an increased effectiveness of phototherapy. And these light variables usually are inbuilt in these LED, we don't need to bother with that. So as far as the side effects of phototherapy are concerned, it is relatively very safe. So nobody literally bothers about any significant side effects. In fact, there are some proposed side effects like genotoxic, oxidative stress effects, and the immunomodulatory effects, which are some real concerns actually. And even in the long term, some would think about acute myeloid leukemia and melanocytic nevi, some allergic diseases. But most important acute side effect will be the interference in the mother-child relationship. So that is one thing which is very much hesitant to use a prophylactic phototherapy for all, and NNF gave a clear recommendation that prophylactic phototherapy is not recommended even in the setting of an RH or ABO. So unless, because it has its advantage, because it interferes with the breastfeeding. So that is one thing which has to be kept in mind. So again, based on the same concept, and we use typically the AAP guidelines or the NICE guidelines. So these are the recommendations by NNF. So in more than or equal to 35 weeks, so either the AAP guidelines or the NICE guidelines are advised. And in preterm babies less than 35 weeks, we use the Masel's chart or the NICE guidelines. So these are the typical AAP guidelines which everyone is aware of. And there will be 3 curves for 3 risk categories, and 2 charts for one for phototherapy and one for exchange. And in the Indian setting, because we have some inbuilt genetic makeup which makes us prone to jaundice, and there is a significant higher proportion of SGA babies in our setup. Ideally, it should be 10%, but we have around 18 to 20% in our single potential. And non-availability of intensive phototherapy in many non-parents. In one of the studies in 58 units across 24 centers in India, it was observed that only 9% of the units have the recommended intensive phototherapy ranges, and 31% of units are giving irradiance at least 15. See the amount of phototherapy. So this is the variability that we have. And this has been taken into account to a larger extent by replacing all with LED phototherapies, which require very minimal maintenance nowadays. And these are the Masel's chart and NICE guidelines. It's NICE guidelines, and nowadays there are some very good apps for it. Even you can have in your mobile phone. Biliguru is one such app. You just have to enter the age and it will plot it nicely and tell you, and it will tell you the phototherapy threshold and exchange threshold. So NICE guidelines are also freely available actually. So these are things which are recommended. Coming to phototherapy, it should be the one thing which we want to avoid is the disturbance with breastfeeding. So ideally recommended is that we should start phototherapy at the mother's side whenever possible. That's easily said than done most of the times. I do agree upon that, but generally we try to start phototherapy at the bedside as much as possible. And we have the concept of NICU coming, and where we try to put as much as possible along with the mother. And no routine changes in body positions are recommended, and continuous phototherapy with occasional changes, nappy changes, and breastfeeding interruptions are allowed in between. So intensive phototherapy is the norm. Whenever we talk about phototherapy, it's equated with intensive phototherapy nowadays. So it can be a single or multiple devices. Multiple devices preferably used when the irradiance from a single device is low. That is a typical scenario where it is considered actually. And how frequent we have to measure bilirubin? That is the next question, and that's only on an expert consensus, no rigorous studies regarding that. And usually when values are near exchange, we repeat it once in 4 to 6 hours to make sure that the phototherapy, that the bilirubin values are settling below exchange. And once it has come to stable levels, we repeat once in 12 hours if needed. And follow bilirubin after discontinuation may be seen after 12 to 24 hours after discontinuation. So when to stop phototherapy, recently this guideline has been changed. The phototherapy can be discontinued when serum bilirubin is at least 2.9 milligram per deciliter below the treatment threshold for that particular age and specific chart lengths. So a single value below this value is enough to discontinue phototherapy in non-hemolytic jaundice, where if it is a hemolytic jaundice, we need 2 values below the threshold to stop it, to ensure that the rebound won't be crossing too high. So that is the recommendation, recent recommendations. And the other important therapy is exchange transfusion. So we decide whether to do based on the chart value and also the level of sickness in the baby and the likely etiology and the presence of encephalopathy, bilirubin encephalopathy. So this chart indicates that as the level increases, the free bilirubin levels increase exponentially. You have to keep that in mind. So it's not just a linear association. As the values increases beyond your exchange cutoff, it increases exponentially. So you have to be very vigilant in treating that at the earliest. So the risk factors for encephalopathy for a permanent damage in the brain would be a presence of acidosis, low albumin levels by which some of the SJ babies can have, and some blood-brain barrier disruption, which include asphyxia, sepsis, and hemorrhage, and ongoing hemolysis, and other displacers of bilirubin from the blood, which includes free fatty acids from intraliquid or Brufen. So these are commonly used in preterm babies where you have to keep in mind. So these are the risk factors which you keep. And one thing is very clear right now. Previously, they have recommended intravenous immunoglobulin for alloimmune history and due to AVO or RH incompatibility. And that was based on a Cochrane review, though it is equivocal. AAP gave a recommendation previously to administer IVIG when the near exchange values. But now the recent 2018 Cochrane update, they have placebo control trials which are included in the study. Though it is a very small sample size, they are of enough evidence of moderate quality, which is very difficult to shrug off. And they gave a very clear recommendation that IVIG was ineffective in preventing exchange transfusion or top-up transfusion. So this is when placebo control studies have changed the outcome literally. When without a placebo, they show that they are useful, and placebo control studies say clearly that it is not useful. So it's it's about not the use of exchange alone, it's also for the need for top-up transfusion, duration of phototherapy, and the incidence of long-term adverse effects. So they gave a clear recommendation that IVIG is not recommended either prophylactically or therapeutically. So the next thing is that breast milk jaundice, various theories are put for that. So ultimately, I would like to stress upon here the same thing. Bilirubin, some amount is beneficial. We should not neglect that fact. So we should not try to rigorously bring the values to 0 or so. So especially this, we think of breast milk jaundice when it goes at somewhere around 2 weeks of age. So at this age, usually the blood-brain barrier is also mature. So the risk of your bilirubin crossing and affecting the blood-brain barrier is a little bit low. And breastfeeding discontinuation is not recommended either for diagnosis or for treatment of breast milk jaundice because it is usually a benign and self-limited conditions. May require phototherapy as per the guidelines for a brief period of time. And with the LED phototherapies, very intensive phototherapies, and we can have some reduction even after some 10 to 14 days of age. All the other alternate therapies like albumin prime prior to exchange transfusion, zinc, phenolphthalein, fibrates, agar, tin mesoferrins. So all these are not recommended. So just underlines the fact that nothing is going to compete with your phototherapy, which is considered far safer and far easily available nowadays. So all those have literally lost interest nowadays. The only thing is that fluid therapy, especially in the setting of breastfeeding jaundice, especially when it leads to severe hyperbilirubinemia while awaiting exchange transfusion or in the near exchange range, fluid supplemented infants are less likely to require exchange transfusions. You can consider fluid therapy, 10 ml per kg per hour for 6 to 8 hours. So that is the thing which we need to do. And all these high bilirubin babies need to be followed up with BERA before 3 months of age to identify any hearing dysfunction and needs to be corrected appropriately. For all neonates more than 30 or who need a blood exchange transfusion, it's mandatory to do, followed by a proper neurological examination for long-term side effects. Okay. The last few slides will be on neonatal cholestasis, which is again a different topic from indirect jaundice altogether. So it is defined by a serum conjugated bilirubin of more than 1 milligram per deciliter when total is less than 5, or more than 20% if total is more than 5. So we commonly use what is called as a Vandenberg test. So there is some terminological differences where we call it as direct bilirubin and conjugated bilirubin are not the same actually, though literally can be equated, just technical terminologies. And this delta bilirubin is something which is bilirubin bound to albumin. There are some clinical implications of understanding the concept of delta bilirubin. I'll just come to that later. And this Vandenberg, the traditional test reports as direct bilirubin, or the modified Vandenberg uses some fraction, some chemical to dissociate from the bilirubin and albumin, and they measure the pure conjugated forms. So this is a commonly done test. So why it has to be diagnosed earlier? Why are we at all worried about cholestasis? Is that we all know that diagnosis of biliary atresia must be done before 60 days of age because early intervention improves long-term outcome. No doubt about that. But what we miss to identify is that there are some other things which are also change the course of disease by diagnosing it earlier. So one is that it reduces the risk of hemorrhage from vitamin K deficiency. And another is there are some diseases where, which are rapidly life-threatening, but potentially treatable. So these are the things which should not miss actually. So our aim is to identify these things as early as possible, which include typically a bacterial sepsis, gram-negative infection, some endocrinopathies like panhypopituitarism and galactosemia and certain inborn errors of bile acid metabolism. So what is the all fuss in diagnosis which causes a delay in diagnosis? There are various reasons cited. We are all aware of all these things. So early discharge without a follow-up, and the normal course of bilirubin after birth is that it will reduce. As I said, it will reduce even without therapy after some point of time, and the patient will think that it is getting settling. But actually, conjugated bilirubin may start rising after some 2 weeks of age. So we have to keep that in mind. Apparently well-nourished infant, even if there is a biliary atresia, there are significantly reduced fat stores and lean body mass, but that is compensated to some extent by edema and herpes simplex, and you have normal weight and literally nearly normally looking skin because of some amount of edema. And being misled by pigmented stools, and where the intestinal epithelial cells are covering the faces, and they cause some problem. And we often misthink like it's a breast milk jaundice, which is relatively very common cause of unconjugated jaundice. And inadequate investigation of a hemorrhagic disease, and yellow urine because of some vitamin supplements. So all these can cause some delay in diagnosis. You have to keep that in mind. This stool card is definitely going to change the, will help you in identifying it earlier. It's always better to have that actually, or even you can have it in your mobile and show it to mother whether the stool is something like that, or if you have the opportunity, always visualize the stool, which color it is at. So it should not be pale. Clay colored stools, by which you mean it's China clay, it's a clay colored stools. The abnormal pale stools, it has to be identified as earlier. These have some proven benefits in identifying it earlier. And as a clinician, I'll be worried about other pointers towards the clues because the etiology of neonatal cholestasis extends. So what we need to look at is some evidence of congenital infection. And one important pointer for a metabolic disorder is a profound impairment of synthetic function, unexpected for the degree of cholestasis, leading to some bleeding diastasis, and hypoalbuminemia will be very prominent. So that is one thing. Another neurological abnormalities, the primary abnormalities may be seen with mitochondrial and Zellweger syndrome, and there can be secondary to hypoglycemia to the scenario. And other clinical pointers like dysmorphic facies, congenital malformations, and choledochal cysts, which can present to the mass in the right upper abdomen, also has to be identified. So these are the typical clinical examination findings which one doesn't want to miss upon. And more importantly, you have to get an off-thal consult. So off-thal consult is mainly to look for evidence of Alagili syndrome, a posterior lenticonus, optic nerve hypoplasia, or chorioretinitis in congenital infections, or cataract or coloboma in certain syndromes. So for all these, off-thal evaluation is very, very important. Okay, and now coming to only 4 tests. With that, I'll end my talk actually. So one is the biochemical test of liver. As I said again, the aim for investigating is to confirm cholestasis, to assess the degree of injury, and assess synthetic functions. So synthetic function is always albumin, prothrombin time, and to some extent ammonia. And assess degree of injury, by hepatocyte injury by using the liver enzymes. Confirm cholestasis by taking bilirubin. So again, I have to keep in mind that whenever there is some poor hepatic synthetic functions early during the course of illness, we often think of inborn errors of metabolism or intra-retinal infection. And in most of these metabolic disorders, you can typically see that the liver enzymes are normal because the liver injury is apoptosis rather than necrosis. So you don't get a raised liver enzymes in these. And by including GGTP in your gamma glutamyl transcriptase in your panel, you can identify certain disorders where you have a low GGTP and high serum alkaline phosphatase. This combination is very peculiar for certain bile acid synthetic defects and BRIC and PFIC, benign recurrent intrahepatic cholestasis and progressive familial intrahepatic cholestasis. Coming to ultrasound, I just want to clarify only one thing, which is a very common mistake done by most of the PGs. Whenever there is some obstruction distally, you get dilatation of the bile ducts. That is what is expected. But in biliary atresia, the problem is not just an obstruction, it's a dynamic obstruction. By which I mean the ductal proliferation progresses from distally into the liver. So literally all the biliary ductules are involved. So you don't get dilatation of the common bile duct in case of biliary atresia. Whereas in case of some cold ductal cyst or other things, you can get a biliary duct dilatation, bile duct dilatation. So this bile duct dilatation, if present, you have to rule out surgical causes. That is, it's not a feature of biliary atresia. So features of biliary atresia will be non-visualized or small or absent gallbladder and CVD, and hypertrophic hepatic artery. And if Doppler ultrasound is there, you can look for the DAR sign, which are rare literally. And the triangular cord sign, though it is specific, it is very rare. It's present only in around 15% of biliary atresia. So other thing is liver biopsy. I would stress more importantly, this is the most useful investigation. It is relatively safe. It can be done under local anesthesia and sedation. And it is the single most important investigation. It's 90% specific for diagnosing biliary atresia. Can be ambiguous in 10%, especially if done early. And three important things you can get information. Either it is these three are the typical patterns. You have to just fit in this pattern as much as possible. In late stages, everything will be necrosed and you will not be useful. In early stages, you can see for evidence of bile duct proliferation, which is very typical for biliary atresia, or giant cell transformation, which is very typical for neonatal cholestasis. And there can be some paucity of bile ducts, and the various spectrum of disorders can be seen. There is a paucity of bile ducts. Coming to scintigraphy, this is more of a, it has a limited role, as I can say, and withholding biopsy for doing a scintigraphy is not acceptable. The sensitivity of scintigraphy can be improved by pre-treatment with phenolton for at least 3 days. It's expensive. It's relatively poorly specific. There are two things which you can see in scintigraphy. One is the uptake of hepatocyte function and the excretion of the isomer. So the uptake is a function of hepatocytes. So in hepatitis, you get reduced uptake, but normal excretion. In biliary atresia, you get normal uptake, but no excretion. So these are the two things that you can see. One is uptake and excretion, which can be help you in some amount of diagnosis. And coming to the medical therapy, this is what I say. There are certain treatments, medical treatments available for some of the aspects of your neonatal cholestasis. Keep that in mind and investigate rigorously for this so that you won't miss a treatable cause. For example, dietary treatment modifications are available for galactosemia, fructose intolerance, and tyrosinemia. And nitisinone is a drug for tyrosinemia. And you can intake of foods rich in protein and lipids will change the course, and you can supplement with pyruvate in case of sectin deficiency. And cholic acid can be useful instead of UDCA in defects of bile acid synthesis. There are some other diseases like Niemann-Pick disease where the enzyme replacement therapy is available. And hormone replacement for pituitary insufficiency, antibiotics, and specific therapy for CME, and neonatal hemochromatosis, now called the gestational autoimmune liver disease. For all these disorders, some medical management is available. So whenever possible and not fitting with any of these, you always try to rule out these treatable causes. Keep these in mind. There are various other etiologies which are not going to change. You can have some time to diagnose that also, but identify these things at the earliest. That is your aim of thing. UDCA has been the traditional first-line therapy. It's far safer. The only common side effect is diarrhea, which usually responds to dose reduction. So how you can get a better quality of life in chronic cholestasis is that there are three problems. One is retention toxicity, which you have to monitor frequently. And another is the transfer to circulation causing pruritus and xanthomas that can be treated somewhat medically. Unobstructed bile flow leading to malabsorption and fat soluble vitamin deficiencies can be supplemented to some extent by your increasing calorie intake and 2 to 3 times RDA for fat soluble vitamins and your vitamin supplementations for at least 3 months after resolution of the disease, because it takes some time. The typical surgery which is done for biliary atresia is Kasai's photointerostomy. And this Kasai, when you say that a success of surgery is that the restoration of jaundice usually takes some time. This is where your concept of your delta bilirubin becomes very important, because the half-life of albumin is around 21 days. So you need around 2 to 3 half-lives for all the bilirubin to settle down. Even after you are making a channel for the flow of bile by surgery, the jaundice doesn't settle immediately. It takes some time. So resolution of jaundice usually takes around 3 months. So if there is no resolution of jaundice by 3 months, it means that Kasai has failed. So don't be in a hurry to say that your Kasai has failed in the very early course of time. And 80% of those even who has been done a Kasai transplant ultimately will require a liver transplantation by age 20 years. So always register them for liver transplantation registration. I think these are the things I would like to, I have just covered some of the doubts or some of the frequently asked questions in your management of your neonatal jaundice. I'll be glad to clarify more questions if any of the audience have it. So the take-home messages will be: early onset, rapidly increasing jaundice, always rule out hemolytic etiology. Breastfeeding jaundice, always try to treat the cause, correct the breastfeeding technique and all, and rather than just treating with phototherapy. Phototherapy and vaccine transfusion are the primary treatment if unconjugated. Start phototherapy as far as possible at the bedside. And this is called as the spectral power of phototherapy. It's not only the irradiance, but also the amount of exposed body surface area that is important while taking care of a baby under phototherapy. Know the pitfalls of delayed diagnosis of neonatal cholestasis. Don't fall prey to that. And don't delay a liver biopsy in diagnosing the etiology of neonatal cholestasis, which is the most useful. And don't miss to diagnose the treatable causes of neonatal cholestasis. So this will be my take-home messages, and I thank the organizers. Remember that yellow is at times difficult to predict. We don't know how it will predict. So be better aware of all the pitfalls. Thank you.
Thank you, Manikumar. Such an exhaustive presentation on jaundice, covering most of the questions as a form of answer, and introducing some new modalities of a diagnostic tool like BiliCam and stool card. And Dr. Vishwanathan has put up on the chat box that as important tool is urine examination also is important in assessing a cholestatic jaundice. Yes, it is well taken. I think one needs to, in cholestatic jaundice, not look at pale stools, look at the urine also and examine it to find out whether we are really dealing with cholestatic jaundice. And is there any other newer modality in the treatment? You told us phototherapy. Now you have peculiar situations like what is happening in Sri Lanka with a lot of power cuts. With most NICU may go out without power, and the phototherapy units actually they may not be able to work. Is there a solution for that? We know we have solar energy that they can use, but is there any other option directly use sunlight as a phototherapy?
Filtered sunlight has been tried to some success actually. Filtered sunlight is a possibility, especially in resource limited settings. But I don't see the utility as far as our Tamil Nadu is concerned. So Tamil Nadu is literally surplus with
commercially available products of sunlight tents where it filters off the heat and thing, and you need to put the baby inside those tents and keep it directly under the sun. I think such type of devices may probably be useful when you have long duration these power cuts, or where probably you do not have sunlight at all. In some countries, I was told sunlight hours are very low and they need to depend on only electricity for your phototherapy to work. I think, is there any questions, other questions? I thought this FAQ that may from the chat box, I thought I'll get more questions. There any questions from the audience?
So based as what is the effective distance between source of the light and baby? As I said, it's as low as possible in case of LED phototherapy without causing any hypothermia. Actually, it can be as low as 10 to 15 centimeters also. But reducing below 15 centimeters, we usually will have a reduced exposure in the body surface area because the light will fall on a focused area and some of the skin may not receive the complete phototherapy. So we will not be able to reduce the distance beyond. But in cases where CFL is used, we typically keep it at around 25 to 30 centimeters because reducing that will increase the heat generated actually. Because the narrower the spectrum, the lesser the heat that is generated. CFL has a higher spectrum relatively, and sunlight has even a higher wavelength, higher spectrum. So the energy is very more that the incidence of hypothermia is very high if you put directly without filtering sunlight.
I think if there are no other questions, I think we'll finish topic. We have exceeded the probably assigned time for this session. And I think the next session needs to start. Thank you, all the speakers. You have done an excellent work. We have learned a lot today. Thank you very much.
Thank you, sir. Thank you very much for conducting the sessions and deliberating the discussion, sir. Thank you very much, sir. May I now request Professor Kumudha ma'am to just take over the stage, please.
Okay. Thank you, Dr. Tirumurugan. Good evening to one and all. At the outset,
ma'am, your volume is a bit low. Can you just get the mic a bit closer, ma'am?
Yeah. Like I would like to thank PNSC for giving me this opportunity to chair this session. I know we have exceeded time. Hope the speakers will stick to the time so that more questions could be answered. And now I invite the first speaker on this session, Dr. Abhiramalata. I don't think again she needs any introduction to this august audience. Dr. Abhiramalata is a neonatologist currently working in Coimbatore, and also she has got so many research publications to her credit, and also she is associate professor and consultant at KCMC, that is in Coimbatore. Also, she has won Young Researcher Award. The problem she is going to deal with is challenges in late preterm. I think feeding is one of the issues or one of the interventions which is taken very lightly by all of us, more so even if it is a preterm, because we with the flurry of repeat cesarean sections which is done for all late preterm babies, despite the recommendation of repeat cesarean to be done at after 39 weeks, we still see a lot of late preterm babies being delivered, and there is a lot of problems in feeding them. I think Abhiramalata would bring out all the problems and more about support of those babies, which needs to be done by us, especially the primary caregivers. Over to Dr. Abhiramalata.
Thank you, Kumudha ma'am, for the nice introduction, and I thank the organizers for giving me this opportunity. Ma'am, I'm not able to share the screen.
Just Dr. Tirumurugan, could you help us?
Yeah, please try now.
I think she has to be made as co-host. We could see the slide, Abhiramalata.
Yes, ma'am. Thank you, ma'am. Good evening, everyone. So the next topic for the day is challenges in feeding late preterm neonates. So late preterm babies contribute to a large number of babies that we deal with day-to-day in our day-to-day practice, because the late preterm infants contribute to 65% of all preterm births, and they contribute to almost 10% of all the births. And data shows that there has been a significant increase in the number of late preterm births in the last 2 decades. Like how Kumudha ma'am said. So according to US data, there is a 25% increase, and according to Australian data, there is a 40% increase in the number of late preterm births in the last 2 decades. So the late preterm babies are the great dissemblers. Why we say like this is because they look like they are well babies, because they look almost like that of full-term neonates. So we tend to treat them as full-term neonates. but then they have a degree of immaturity that places them at higher risk of having poor short and long-term outcomes. So if we look at the short-term outcomes of late preterms, around 35% of them will need NICU admission, 12% of them will need respiratory support, 6% of them will need invasive mechanical ventilation, 20% of them will need IV fluids, and 16% will need phototherapy. So these numbers are definitely higher when we compare the same with that of term neonates. And even when we look at long-term outcomes, so the risk of neurodevelopmental disability and the risk of a child requiring special education is higher in late preterms when compared to term. So the late preterm babies are have twice the risk of having neurodevelopmental disability and 1.5 times the risk of requiring special education when we compare them with term neonates. And they are also at risk of metabolic complications like hypertension, diabetes, cardiovascular and endocrine disorders as young adults. So most of the times we consider all these complications only for extreme preterm or very preterm neonates. So we should not forget that even late preterm babies are at higher risk of all these long-term adverse outcomes. So why nutritional management of late preterm neonates is important? Because if we look at the long-term growth, so these babies are at high risk of being stunted or being underweight at 1 and 2 years of age. So when we compare them with term neonates, they are 3 times at higher risk of being stunted at 1 and 2 years or being underweight at 1 and 2 years. So on one side, nutritional management of these babies is important. On the other side, their nutritional management is more challenging. So if we have an extreme preterm neonate, we admit the baby in the NICU and we have a nurse to take care of the baby 24/7. So we have the luxury of managing the baby's nutrition and other management in the way we want. Whereas these late preterm neonates, they have to be managed in the postnatal wards. And apart from that, we do not have robust data on the incidence of morbidities. So we do not know what is the incidence of NEC or feed intolerance in these neonates. And the third most important thing is we do not have standard nutritional guidelines that are tailored to these neonates. So if we see all the nutritional guidelines like SPEGAN or AAP guidelines, all those nutritional guidelines are meant only for very low birth weight or very preterm neonates. So we do not have separate nutritional guidelines for these late preterms. So because of this, most of our units have our own protocols for managing this. These are the admission criteria of three large NICUs in South India. So the admission criteria, criteria for admitting the baby in the NICU varies a lot. So some units tend to admit all babies who are less than 36 weeks or less than 2.25 kgs, whereas other units tend to admit only if the baby is less than 34 weeks or less than 1,800 grams. So the other thing is the feeding options. So there are 3 feeding options if we think of. So one is like we can keep the baby on exclusive breastfeeding. The second option is breastfeeding plus top of Sangu feeds with mother's own milk. And the third option is breastfeeding plus giving some other milk. So as Kumuda ma'am said, and as we all know that exclusive breastfeeding is the best for any baby, especially for preterm neonates. But these babies tend to have issues with breastfeeding. I mean, the incidence of breastfeeding issues in these babies is much more when we compare them with that of term neonates. So if we want to think is only breastfeeding adequate, so they do have some physiological drawbacks. So the first major drawback is they have low glycogen stores. Because 50% of hepatic glycogen stores are laid down between 36 to 40 weeks of gestation. So because these babies miss this crucial period, they have lesser hepatic glycogen stores. And so they are at higher risk of developing hypoglycemia. The second major problem is their brain immaturity. So the brain weight of a baby at 34 weeks is only 2/3 as that of a term neonate. So only after 34 weeks, the gray matter and myelinated white matter increase exponentially to reach the term size by 40 weeks. So because their brain size is low, they have brain immaturity and they are at higher risk of developing feeding problems. So these are the ineffective breastfeeding behaviors that are demonstrated in late preterm neonates. So one is like they have weak suction pressures. So they cannot give strong suction like term neonates. And second is they have less muscle tone. So they have less postural tone. So they tend to slip off from the mother's nipple during feeding. And third is they have diffuse sleep-wake cycle. So their sleep-wake cycle is not robust as that of term neonates. So a term neonate, when the baby becomes hungry, the baby can wake up, cry for a feed, and maintain the wakeful state until the baby finishes the feed. But this doesn't happen in late preterms. So these babies tend to fall asleep early in feeding. So their breastfeeding becomes less effective. And last but not the least, they may have poorer coordination of suck swallow breathing reflexes, which can predispose them to cardiorespiratory instability. So the other major problem in this group is the mothers of late preterm infants are at risk of impaired or delayed lactogenesis 2. So we know that lactogenesis 2 is something which is triggered by withdrawal of progesterone. So this is the one that transitions the mother from just 15 to 20 ml of colostrum on day 1 to 500 to 600 ml of milk by day 4 to 7. So during this period, that is the first week of postpartum period, the number of secretory cells in the mammary glands increase and the density of prolactin receptors in the mammary epithelial cells increase. So all these physiological changes contribute to the onset of lactogenesis 2. Though withdrawal of progesterone is a major factor, so this step is catalyzed by a unique human infant sucking rate and rhythm. So that is, I mean to say that these early days is very critical for the mammary gland. So the mammary gland must receive the timely and appropriate stimulation from the infant. So infant sucking is a very important stimulus for this lactogenesis 2 to set in properly. So unfortunately, these late preterm infants have immature sucking behavior. So they may not be able to give adequate stimulus to the mammary gland. So this increases the risk of delayed or impaired lactogenesis 2. On the other hand, the mother is also having so many risk factors. So preterm delivery per se is a risk factor for impaired lactogenesis 2. And apart from that, the other risk factors are diabetes, PAH, cesarean delivery, high body mass index in the mother, prolonged bed rest, and other intrapartum complications. And if we think most of the mothers who deliver late preterm have one or more. So on one side, we have the baby with immature physiology who has poor sec and immature suction pressures. And on the other side, we have the mother who is also having risk factors for poor lactation. So both these together result in delayed or impaired lactogenesis 2, so which results in less milk production in the mother and lower rates of exclusive breastfeeding to the baby. And the baby also develops lactation-related morbidities. So how are we going to support breastfeeding in these neonates? So we have two major objectives when we want to sustain breastfeeding in late preterm infants. On one side, we have to ensure that the infant is adequately nourished. And on the other hand, we have to protect the maternal milk supply. So we have to do both. Then only we can sustain breastfeeding in these neonates. So how are we going to support breastfeeding? So two things that we can do to facilitate milk intake during breastfeeding are properly positioning the baby and sometimes by using a nipple shield. So we already said that the late preterm infants are hypotonic. They do not have adequate postural tone, especially the flexor tone. So they may not be able to maintain the head and neck position during feeding. So adequate support of the head and neck during the breastfeeding period helps them to suck better, suck in a more effective way at the breast. And the second thing is swaddling. So swaddling the baby again helps to maintain the postural tone, and it helps to maintain the flexed posture of the baby, so which in turn results in better feeding behavior. So adequately supporting the head and neck and swaddling the baby, these two aspects will help in better milk transfer during breastfeeding in these neonates. The second thing is the nipple shield. So because these babies do not have strong suction, so they may not be able to create the nipple shape during feeding. So if we use a nipple shield, that creates a nipple shape so that strong suction pressure is not necessary. And once we latch the infant to the nipple shield, the suction created by the infant creates negative pressure within the tunnel of the shield, and it facilitates milk transfer. So there are studies to show that if we use nipple shield in late preterm neonates, they are able to breastfeed in a better way. So how are we going to assess breastfeeding in these neonates? We know that there are a lot of tools to assess breastfeeding. So one of the best studied tools is this Bristol breastfeeding assessment tool. So where we assess the breastfeeding based on 4 components, namely positioning, attachment, sucking, and swallowing. The second aspect is protecting the maternal milk supply. So we already said that these late preterm neonates do not give adequate stimulus to the mammary gland. So what we can do is we can use a hospital grade electric pump to provide the same stimulus to the mammary gland. Again, there are studies to show that if mothers who use breast pumps during the first week of life are able to have better and more sustained breast milk production than those who did not use breast pumps. Okay, so after taking all these efforts, we can try to maintain the baby on exclusive breastfeeding. But then if the baby if exclusive breastfeeding is not adequate, then the second best option is to give breastfeeding plus top-up Sangha feeds with mother's own milk. So topping up with express breast milk. So what the guidelines and the experts say is it's better not to give each feed as direct breastfeed plus Sangha feeds. So because when we try to do this, on one side the mother gets exhausted, and secondly the duration of each feed increases a lot. And third, whenever we want to give both direct breastfeeding and Sangha feed to a baby, then mother will tend to concentrate more on the Sangha feed than on the DBF, because Sangha feed is something which she is seeing objectively. So she can, she can measure how much milk the baby is taking. So mother will tend to stop breastfeeding, direct breastfeeding earlier, and try to resort to Sangha feeds earlier. So that will affect the direct breastfeeding duration. So the better options are to give alternate direct feeding and Sangha feeds. So that is one feed DBF and next feed Sangha feeds with EBM. So in this way, the direct breastfeeding duration will not be affected, and mother also will get adequate stimulus for her mammary gland. And or alternatively, we can even have periods of DBF and periods of EBM. That is morning hours DBF or night hours DBM, like that also we can do, so that we ensure specific quantity of milk intake to the baby for in a 24 hours period. So the other way of checking whether DBF is going on well is test weighing. So test weighing is not really practical at home in our community. Maybe when the baby is in the NIC or in the postnatal ward, we can do this. So this is nothing but weighing the baby before and after a feed. So the number of grams of increase after a feed is roughly equal to the ml of milk taken by the baby. So for this, we need a much more precise weighing machine to the nearest 1 gram or 2 gram, or at least to the nearest 5 gram. So for example, if there is a 30 gram increase, then we can say that the baby has taken 30 ml of milk from the direct breastfeeding. So whenever we start a baby on direct breastfeeding plus Sangha feeds with EBM, then the transition towards changing the baby to only direct breastfeeding should happen over a few weeks. So we should not be in a hurry to resort to only direct breastfeeding. So this is taken from one of the studies that showed that in the first week of life, the amount of breast milk taken by the baby from DBF is less, but then as the weeks increases, the proportion of milk taken from DBF is increasing. So basically, we can try to get the baby on only DBF when the baby reaches term corrected age. So if neither of these two work, that is neither the exclusive breastfeeding nor breastfeeding plus top-up DBM work, then only we have to go to the third and the least preferred option of giving breastfeeds along with some other milk to the baby. So this is done only if breast milk is inadequate despite all our efforts. And if we want to do this, then the choices are obviously the best choice is pasteurized donor human milk, but then unfortunately PDHM is not accessible or affordable for most of our babies because milk banks are not available in all the centers, and the commercially available PDHM is quite expensive. So the only option we are left with is formula feeds. So whenever we start formula feeds for late preterm infants, we have to understand that they are also at risk of NEC. So the incidence of NEC in late preterm infants is 0.5 to 4 per 1,000 live births. But then if we have no other option, then sometimes we resort to formula feeds. And then the next question is which formula we have to use, whether we have to use a preterm formula or a term formula. So for this, first of all, we should know the nutritional requirements of late preterm neonates. So as I already said, we do not have separate guidelines for late preterm infants. So this is an article where the author discusses the nutritional requirement of late preterm infants. And these are just extrapolated data from that of extreme preterm and term neonates. So if we see the target weight gain of late preterm infants, their target weight gain is around 13 gram per kg per day, which is in between an extreme preterm and a term neonate. And the protein requirement is 3 gram per kg per day, which is again in between an extreme preterm and a term neonate. So apart from these, the calorie requirement, minerals and vitamin requirements of late preterm neonates are almost equal to that of an extreme preterm or a very preterm neonate. So if we look at this data, then we may feel that a preterm formula may be a better choice for these late preterm neonates. But then we do not have robust studies, RCTs or something to prove which is better. So as of now, we are going by weight. So what we do practically is, if a baby is less than 2 kgs, we start the baby on preterm formula. And if the baby is more than 2 kgs, then we start the baby on term formula. And this is mostly based on manufacturers' recommendations. So what about other supplements? The American Academy of Pediatrics recommends that all preterm infants, including late preterm infants, should receive multivitamin and iron supplements until the baby receives diverse complementary diet. And additional calcium and phosphorus, mostly we don't give for late preterm infants. But then when we look at their requirements are same as that of an extreme preterm infant. And these infants miss almost half of the third trimester. So the third trimester is a period when the calcium and phosphorus accretion from the mother to the infant takes place. So because these babies miss half of the third trimester, they may have lower calcium and phosphorus stores. So they may be at higher risk of having these mineral deficiencies. And third is the human milk fortifier. So we don't use a HMF in late preterm infants because none of the guidelines recommend us to use the same. We use it only rarely when the baby is not gaining weight on direct breastfeeding and EVM. Then we sometimes rarely use human milk fortifiers. So these are the three options for feeding in these neonates. So I just want to discuss three small case scenarios. So case one is our ideal scenario where a baby is born at 36 weeks of gestation with a weight of 2,200 grams. The baby was born by vaginal delivery to a G2P1 mother who has exclusively breastfed the previous baby. So basically, other than being a late preterm, the baby mother-infant diet does not have any other risk factor for breastfeeding failure. So this baby was observed in the delivery room for 6 hours. Baby was found to be stable. So baby was given 2 direct breastfeedings under supervision. So basically the feeds were assessed and assisted by a trained nurse and who found that the baby is taking direct breastfeeds well. Baby sugars were normal. So baby was shifted to postnatal ward. So in the postnatal ward, again, DBF was ensured. The baby was taking direct breastfeeds well. Again, sugars were normal. Weight loss was within normal limits. Baby did not have significant jaundice. So the baby was discharged at 72 hours. And this baby was followed up at 1 week, 2 weeks, and 4 weeks. Baby was found to be feeding well and gaining weight. So this is almost like that of a term neonate, but then we had to have some extra vigilance. Then coming to case 2, so this is baby B, born at 34 weeks with a weight of 1,900 grams. The baby was born by LSCS due to maternal PAH to a primary mother. The baby had transient tachypnea of newborn, so had to be kept in the NICU for 48 hours. During that time, baby was given orogastric feeds with formula. On day 3 of life, baby was initiated on direct breastfeeds when the tachypnea settled. So, but baby was found. It was found that the baby was not sucking well. So, positioning and attachment was taught to the mother. So, at the same time, mother was also taught how to express milk by using a mechanical breast pump. So, mother was taught to give sangu feeds to the baby. So, both the baby was discharged on direct breastfeeds and sangu feeds when the mother became confident by day 5. So, baby was discharged in alternate direct feeds and sangu feeds. And baby was followed up at 1 week, 2 weeks, and 4 weeks. And the sangu feeds were gradually reduced. So, and baby was transitioned to exclusive direct breastfeeding by 38 weeks. And after 38 weeks, further follow-up showed that the baby was gaining weight only direct breastfeeds. So in this baby, though we had some itches initially, baby picked up nicely and reached the stage of getting nutrition only by direct breastfeeding by term gestation. Then coming to case 3, so this is a baby C born at 35 weeks with a birth weight of 2,300 grams, vaginal delivery, primary mother. Baby was stable, started on direct breastfeeding at birth and discharged on day 2 of life due to parental request. So on review at day 5, baby was found to have a 17% weight loss. Baby also had hypernatremia, oliguria, and significant jaundice. The baby was managed with phototherapy and fluids. On breastfeeding assessment, the healthcare workers found that the baby was not attaching well and mother's milk secretion was also less. So baby was started on formula feeds transiently and mother was started on lactobox and the positioning attachment was taught to the mother. And this mother-infant diet required 5 days of hospital stay to re-establish breastfeeding. So this whole readmission and the morbidities could have been avoided if we had kept this baby for 1 more day and assessed breastfeeding and made sure that baby was feeding well before we could discharge the baby. So I want to finish off saying that adequate vigilance is the key. So though these late preterm infants can be managed like that of term neonates, we just have to take certain extra measures. So if we want to shift the baby to the mother side soon after birth, it is essential that we have a 4 to 6 hours observational period in the delivery room itself. So during this period, we have to make sure that the baby is maintaining temperature, baby does not have any respiratory distress, and the baby is maintaining saturation, and baby is taking direct breastfeeds well. This should be assessed by a trained nurse, and blood sugar should be normal. And even after shifting to postnatal ward, we have to a trained nurse has to assess at least 2 feeds per day for the first 2 days. So this will help in both assessment and assistance so that the mother becomes confident of giving direct breastfeeds. And sugar monitoring for 48 to 72 hours is essential. And we have to make sure that the sugars are normal. And daily weight check, we have to make sure that the baby is not losing weight more than 2 to 3% of birth weight every day. And the discharge. So discharge is one major factor, especially because of many of the parents' financial situations. They want to have early discharges. But AAP specifically recommends that late preterm infants should not be discharged at less than 48 hours. So AAP guidelines state that discharge at less than 48 hours is only for term units and not for late preterms. In late preterms, early discharge itself is defined as discharging on day 3 to 5. And that is done only after ensuring that all is well. And the lower the gestation age, the later should be the discharge. And after discharge also, again, we have to have a weekly or at least a bi-weekly review until the baby becomes term to make sure that the feeding is going on well and the baby is gaining adequate weight. So if we are ready to take all these vigilance measures, we can manage the baby, manage late preterm infants like that of term infants, and we can discharge them on exclusive breastfeeding. Thank you.
Thank you, Dr. Abhiramalata. To bring out all the problems late preterm actually undergoes and the type of nutritional support or the breastfeeding support we have to give. I have few comments. Before that, I think there is a question from the person in the chat box. 1 minute. What is a remedy for mother with inverted nipple other than formula fed initial?
Yeah, so inverted nipple is one major problem. So the problem with inverted nipple is more than the mother, the nurses get very much, dissatisfied if a mother has inverted nipple. So we know that a nipple is not a major problem for feeding because the baby has to latch on to the areola. So, but then to initially latch, maybe the baby may need the nipple. So mostly if it is only a flat nipple, then just finger stimulation itself may bring out the nipple in many mothers. So just stimulating the nipple, rolling out the nipple with fingers itself might help. But then if the mother has very much inverted nipple, then we may have to use a nipple puller or sometimes an artificial nipple like how I showed. So previously we were using the syringe technique, but the syringe is very crude. Sometimes if the mother pulls out very, very fast or very vigorously, she may develop a cracked nipple and the nipple may start bleeding. So these nipple pullers are available now in many brands. So it is like a bulb sucker that we used to use previously for suction, oral suction during deliveries. So that will give a little less pressure and it may be less traumatizing to the nipple. So we can use a nipple puller. And if that is also not working, then many mothers nowadays are comfortable with using a nipple shield. So we can try that as well.
Okay, Dr. Abhiramalata, I have a few comments on your talk. One is for breastfeeding a late preterm, we need definitely one person to initiate feeding in the labor, not just give the mother for feeding and expect her to feed on her own because the child has a handicap and the mother has a handicap. And number two is maybe in the first few days, hand expression would be better because that brings out much more milk than breast pumps, because especially if she's 34 to 37, when you use a hospital grade pump, she may get 1 or 2 drops which she looks at the bottom of the bottle and gets very dissatisfied. So that will be another thing. And again, weighing, daily weighing seems to be good in monitoring how the feeding goes. But there is also an added stress added to the mother, not only to the mother, to the health personnel also. They keep looking at what is the percentage and do things. So we should be very cautious when we are doing the weighing. Don't do it, overdo it, or not do it at all. So that is another thing. And again, you said, like people have to resort to formula feeds, but now most of the cities are having milk banks. So you can have an hub and spoke model where one center acts as a CLMC, that is Comprehensive Lactation Management Center, and the other centers can send their milk for pasteurization and collect the pasteurized milk if they do not have the milk bank. So that is a model which the government of India is now recommending, even in a private sector. One hospital can act as a CLMC, and other spokes can add as a center which they will send or collect milk from the CLMC. That is another thing. And use of nipple shield. Though you showed the silicone nipple shield, which is supposed to be good, but when we use a nipple shield, people tend to use that plastic thing with a nipple shield. So you should be very cautious when you are using that nipple shield. I think we should try to avoid it as much as possible, so that we could give much more lactation support, and that should be the very, very, very last resort. Don't give it, maybe I would advise it to very inverted nipple person, but not for the routine person use of nipple shield if the baby is failing to latch on. What they need, as you said, head and neck straight. So during positioning, they need lot of support, and one person has to stay there, not just initiate and walk off. The nurse has to stay. If the baby comes off the breast, they have to sit there and help the mother. And another important thing which we have to do whenever we are assessing or doing the early discharge, we have to do the assessment score. That is, breastfeeding assessment tool should be used before they send. If the child has a low score, it would be a good advice not to send. And early discharge, as adopted in uh, America or UK, cannot be just copied here because we do not have the community nurse, especially if at least for the children getting out of a government hospital, we see a community nurse has to follow. But person who is getting discharged from the private hospital does not have a community nurse follow up. Unless your hospital has some follow up system, it is very, very incorrect to discharge them before 48 days, just copying the Western world. Like now, hospitals have packages. So they discharge on the third day, even a cesarean mother, especially a late preterm repeat cesarean, and the babies come back to us with lot of problems. I think these, unless a community nursing system or a home check is available for how to see like whether breastfeeding is going correctly, then I think we are not very, very safe in discharging babies early. These are the comments. Thank you for a good presentation, Abhiram Lata. We would move on to the next topic. If somebody has got any questions, you can put it in the chat box. We move to the next person, Dr. Sendil Kumar, who would be talking on care bundles in NICU. We know that care bundles are nothing but set of interventions which will be doing, which is evidence based, which would improve the outcomes in newborns. And there are many care bundles, I think, which Dr. Sendil Kumar would be alluding to a little later. And he is a professor, associate professor in Coimbatore Medical College, the neonatologist who's been working very good work in Coimbatore, and they have one of their low rates of unit mortality among the SNCUs in Tamil Nadu. Over to Dr. Sendil Kumar. Sendil, you can take over.
Yes, ma'am. Thank you. Thank you for your kind introduction, ma'am. Good evening. So first of all, let me thank IAP for giving me a chance to speak in front of my guru. Thank you, ma'am. So I was told that this is basically for a primary care persons. This is for primary care persons who will be handling neonates. So I thought, let it be lively. So I asked for 10 members, I asked them to 10 members whether, do you know about care bundles? The topic given to me was role of care bundles in NICU.
Sendil,
Madam?
Full screen your slides?
Yes, madam, it's already in full screen.
No, it is not.
It's not coming now.
Yeah.
So,
it's okay.
Now again I will share, madam.
Yeah.
Now, ma'am?
Yeah, good.
Okay, fine. So, I thought we'll discuss among the pediatricians about their awareness about these care bundles. When I asked them, almost 80% of them ask care bundle. What do you mean by care bundle? This is what they asked. So I thought, in spite of going into evidence base of care bundles, what evidence base is behind this WAP bundle, CLAPSI bundle, and the sepsis prevention bundle, let me give you a few thoughts about bundle cares in NITU. Basic thoughts. Even a primary care person who is looking after neonates needs to know about this care bundle. Yeah. What is basically care bundle means? It's a set of interventions that, when used together, significantly improve the patient outcomes, because all of us, we need to improve our patient outcomes. For this, we need a multidisciplinary teamwork which has to find out the problem. They need to formulate a plan. They need to work out the plan, and finally, they should enjoy the good, improved outcome. This is what basically care bundle means. Let us make it very simple. By definition, it is a group of evidence-based intervention when executed together resulted in better outcomes. That is, for example, we know the major killer in our premature babies beyond first week is sepsis. So almost we all know hand washing, definitely useful. Yeah, reduces infection. Yes. Next, frequent daily changing of patients' bed sheets. Yes, definitely. Yes. Then, and sterilizing your hands. That is, keeping your hands sterile before and after touching the baby. Even each and every equipment which is in touch with the baby has to be taken care of. All these we know. Appropriate use of antibiotics. All these steps we know. We all know antibiotic has a greater role in treating sepsis. Then hand washing is useful. But when it is done in a haphazard way, we won't succeed. Probably if we have a very high success rate in newborn care, probably we are lacking somewhere. Probably we need to formulate a plan which has to include the major. Already what we have taught, hand washing is the major thing. First, we should take care of it. And in association with the baby, the seats, gadgets, all those stuffs which has to be taken care of. All this has to be enlisted, and we should make a plan. We should make it as a guideline. And before that, formulating the guideline, because always what we, most of the policy things which won't work in the field work is the non-involvement of the workers. Basically, if you want to take care of the gadgets and warmers, all those steps, we need even the healthcare workers. We need to include them in our team, along with our major nurses, even the junior most nurses. Nurse who is going to prepare the fluid. Though fluid or antibiotic will be given by our senior nurse, the preparation will be done by junior nurse. We should include them all, and we need to formulate. We should talk to them in accordance to our own unit, maximum what we can give. This is how we need to formulate, and then we need to establish. First and foremost, we should teach about the importance of the problem, and we should include them in the process, and we should get their inputs. We should formulate a plan. In between, if they face itches, as a team leader, we should help them in managing all those steps. And at the end, definitely, if you have followed, because each and individual point has evidence-based, when it is grouped together, that is bundle of care, definitely the outcomes should be fruitful. Yeah, this is what. First of all, you need ideas. For example, sepsis, that's what I told. More than 1 week of life, if sepsis is more, yes, you yourself build a care bundle. Steps. First of all, from where the baby is from, labor ward. Okay. There, concentrate from there, receiving the baby and receiving in your ward and all those steps. You build a guideline, educate, then use. This is what, measure, and then you need to track. You keep on need to track. For example, the sepsis rate may be 30%. It may come down to 10%. If you want to go below 10%, you need to again rephrase, again replan, because all those steps, if it is made as a routine, further reduction, it needs what? Prevention activities like preventing prematurity, all those steps. So in this evidence-based practices, group together using your patient populations, and almost the basic motive behind this bundle care bundle is every healthcare provider has to be involved. We should get inputs before defining a plan. That is what, before defining a plan, because they are the persons who will know. We will be telling them surfactant, even if it comes by 1 o'clock, even if X-ray is not available, if the features are corresponding to RDS, give surfactant. But the thing is, the storekeeper may not be available. So we need to include them. How to keep, at least on an average, about in a month, about 4 babies comes after 12 and before 8 o'clock. So you can keep few vials of surfactant in our local fridge. Like that, all those stuff which has to be taken care, and it has to be collectively performed. When there is a hitch, it has to be improvised, and at the end, both these you can achieve: improved patient outcome and reduced healthcare costs. So this multidisciplinary team, which has to be included throughout your bundle care processes, all those attending physician, clinical specialist, leader may be one who may be governing it, but it has to be done. We need to include all this multidisciplinary team to execute a bundle care. See, these are the bundle care, it's already in process. CLAPSI, that is CLAPSI bundle means CLAPSI prevention bundle. Perinatal care bundle to give maximum outcome of a baby. To maximum outcome in the sense both in mortality and morbidity. Even hospital stay we can include. Then BPD bundle, prevention of BPD. Sepsis prevention bundle. Even I thought of leaving some blanks, because you are the person in your unit, you will be knowing what is the major problem in your unit, what is running on. In monthly audit, you may be knowing your own problem. You create your own problem. You create your own bundle. You involve your people. Get it done. That's what. Even this bundles of care, these are proven cares, but you have to individualize for your unit. Okay, let's talk about this CLAPSI, that is central line associated bloodstream infection bundle. What they have done? See, they have framed central line initiation bundle and central line maintenance bundle. If we follow these rules, almost we can reduce this CLAPSI rates in your unit to a bare minimum, because all these individual cares is having adequate evidence base. See, maximum barrier precautions, hand hygienes, chlorhexidine skin preparation, optimal site selection. More, see, if you don't practice this hand hygiene, definitely you are going to give some infection to the baby. More often they say gram-negative bugs will enter into. Skin preparation, definitely we need to prepare skin. Optimal site selection, if you select a site in between the joints, definitely it's going to create trauma and which may act as a nidus for infection. Daily review. Just putting a line won't complete this. You need to review the line. This is about the central line insertion bundle. Maintenance, same. Hand hygiene, aseptic technique for accessing and changing needless connections, standardized tubing changes. You need to have your own guidelines. If you have any adverse, for example, putting an intracat, if any appearance of just redness in the tip, sir, this is our unit guideline, we'll take out. It's not that, sir, after 24 hours, we'll change the vent plan. It won't reduce the infection rate. But giving all those steps, creating a definite guideline may reduce it. Standardized tube changing, daily review of catheter. So even in UK, they say, when I talked to a senior consultant there, he told in 23 weeker, sir, how you are maintaining this CLAPSI bundle, how you are giving TPN. He told for TPN alone, they are a separate team. And for TPN nutrition alone, there will be a nurse who will be coming in spite of the routine care being given to the neonate by the neonatal nurses. Just for TPN alone, a sister who is not involved in primary care neonate, because they think even though they wash their hands, they can sterilize their hands, they think they may receive some gram-negative bugs in their hand. So the sister who is not involved in primary care neonatology, she will come. She will be given off for a month, and she will come and she will almost touch those access points, and she used to take care of those knobs. This is what so this is how it was being almost all the parameters will be included, and it has to be done to reduce the bloodstream infection to the minimum. So bundles tested, this is what I told you, plan, do, study, act, cycles, significant and sustained improvement in reducing collapse rate in NICU. Likewise, ventilator, how to prevent ventilator associated pneumonia. We need to try. First of all, first and foremost thing which we are sitting in the era of non-invasive and least invasive ventilation. As much as possible, don't intubate and ventilate, mechanically ventilate. So reducing, for me, if you ask me which is the major strategy to prevent VAPS, ventilate less possible as possible. So, and even if you are ventilated, each and every hour, count each and every hour or even a minute. If you have an option to take the tube out, act as much as early as possible. The strategies which were followed were healthcare professional training, hand hygiene, airways, suctioning, frequent suctioning, it won't reduce. Some visible secretions you are supposed to do. And avoiding re-intubation, planned intubation, you should have a specific guideline. So oral feeding, oral care, even in adult studies, they say using chlorhexidine wipes reduces, but in newborns, you use some colostrum to keep the oral cavity sterile. Then positioning about 15 to 30 degrees, they say reflex reduces, and so the VAP may have a marginal improvement. And the ventilator circuit, about the ventilator circuit, now CDC says even routinely changing circuits within a week doesn't have any improved statistics in reduction of ventilator associated pneumonia. They say even can be kept for 14 days and until otherwise it is soiled. So this is what we are supposed to do. We need to, researchers acts as a change agent. He used to find out the problem. He used to restain. He need to depromote factor. Few things has to be depromoted. Few things he has to monitor, and he need to analyze the utilization of modified neonatal VAP bundle, and at times he may need to change, unfreeze or refreeze accordingly to get a fruitful outcome. So this is about the perinatal care bundle. The perinatal care bundle to give maximum normal neonate. So antenatal steroids, if at all, if it is less than 34 weeks, vitamin K, infection management, that is more often, if you want to give a best perinatal infant care, just deliver the baby on mother's abdomen, allow the baby to breastfeed exclusively, let it be in touch with the mother, that's it. That would be the major perinatal care bundle, but these are the bundle components which they say. But see, by doing that, by practicing that, putting the baby on mother's lap immediately after delivery, and it almost covers everything, prevents sepsis, gives effective thermal control, it reduces the risk of hypoglycemia, all those stuff. Definitely, it may have a major role in giving a best neonatal outcome. Okay, these are the elements of perinatal care. Partogram, that intrapartum management, social support for labor, unrestricted or upright labor positions, exclusion of unjustified procedures like repeated pervaginal examinations. So prevention of neonatal hypothermia, effective neonatal resuscitation, breastfeeding, all these you can attain if you do a practice, if you have a routine practice of putting the baby over mother's lap after surgery. This is BPD prevention bundle. So antenatal steroids, primarily to reduce BPD, definitely antenatal steroids may be useful. Delivery room management, that is early CPAP and early and effective technique of administering the surfactant. Use of antibiotics if needed. It's not a routine. If needed, use of systemic and inhaled steroids. Now the routine use of diuretic or routine closure for PDA in BPD prevention, it doesn't have a bigger evidence. So mode of ventilation, they say volume targeted ventilation has a more role to prevent your BPDs. Tidal volume in accordance to the birth weight, and try to avoid lung de-recruitment, in the sense frequent disconnection of tubes. So oxygen, see, in BPD prevention, they say lower oxygen setting, that is 85 to 91, 92 is enough. Medical therapy, antibiotics, you are supposed to give appropriate antibiotics and IV fluids. Routine restriction of fluids is not mandated. You need to individualize upon each and every baby and optimizing early nutrition and prevention of unplanned extubation. In sepsis prevention bundle, so obtain blood culture prior to administration of antibiotic, administer broad spectrum antibiotic, begin rapid administration of bolus if hypotensive, apply vasopressor and map more than, it's not map 65, it's wrong. Actually, maintain mean arterial pressure in accordance to the gestational age. The same necrotizing enterocolitis bundle, the implementation of the care bundle to reduce the incidence of NEC. Ours unit is a 60-bedded unit where we have around 30 to 40 extreme neonates, that is even less than 1.2 at a single point of time. After this human milk bank, we have started, human milk bank has been started in our unit in the year 2015. After that, this neck rat has dramatically came down. And if we have a concurrent early onset sepsis or concurrent other reasons for sepsis, then we may land up in neck. Otherwise, using this breast milk feeding, incidence of neck is very less. So what they say, in all these elements, you can say, this is what written, let us check, give breast milk, check the tolerance, follow the tolerance. That's it. So I have come to the end almost. Let's start with the story. This is what, when I came by 2014, after finishing my DM from Madras Medical College, ICH, this is what issue was. Sir, almost 60% of premature babies, if the baby receives surfactant, that baby, almost 60% that baby dies. 2/3 of every baby dies. The baby received surfactant, it dies. This is what the phrase which was given to me. It was a bigger problem. Sir, major problem in our unit is, if you give surfactant, baby dies, sir. Something is wrong in the surfactant. I thought, how? Surfactant is a definitive treatment of choice for RDS. Why this should happen? Okay, let me rephrase. If at all the baby is dying, it should be severe RDS or extreme preterm with RDS receiving surfactant. That would be the cause for major mortality at times. Okay, right. It is severe RDS or extreme preterm with RDS. Okay, this is the basic problem here. Extreme preterm with RDS and severe RDS is landing up almost in death, 60% mortality. Okay. Collect the data. So I should know the extreme prematurity but severe RDS admission rate, how much I am getting in a month. Then I need to find out why it is happening. So if I want to reduce my unit's mortality, I need to reduce it. So I need to find out the source, how I am getting this. I need to find out the reason. Most often, sir, majority of the prematurity babies, extreme prematurity, mother had concurrent UTI. Okay, this is a major thing. Definitely, it may be useful for my management in the newborn unit, because if the mother's urine has been sent for culture and sensitivity, and if some growth has been documented, sensitive antibiotic which has been documented, that may be definitely useful in preventing early onset sepsis in these extreme preterms, which may be a major killer in those severe RDS babies. So what is the strategies? How much our OG team is motivated towards antenatal steroids, Maxelf, and if at all concurrent chorioamnitis, their antibiotic stand, and how much they are aware of pushing, that is to reduce the prematurity rates, and also how much, if at all, if I am getting from extramural unit, how much the knowledge is disseminated among the surrounding primary care physicians about in utero transfer, because definitely less than 32 weeker, if at all delivered in a primary healthcare center and then getting shifted and then being given CPAP, surfactant, ventilated, definitely will have a poor rate. That I need to look for. Early CPAP, how much baby has received early CPAP, that is using your TPs or even definitive CPAP from the delivery room, how much baby has received. Then surfactant. How much babies? What is the basic criteria you are using for surfactant replacement therapy? Almost, I found out. These are the glitches I found out. Almost, sir, here 1.5 less than 1.5 only we use surfactant. In the sense, okay, more extreme only they are treating. Okay, that may be the reason. If at all 1.8, 1.9, even can get RDS, but there they didn't use. But even they are using more on these extreme pretiums. Okay, then storage, about storage, they may be kept. When I found out in the stores, medical stores, they used to keep the surfactant in room air. Okay, this, yes, it may alter, it may be hindering the action of surfactant therapy. Yes, methodology, how you are giving the route, and now we know we are sitting in an era of less invasive surfactant administration. Then immediately after post surfactant, what are the things which has to be monitored? Is there any documentation after giving surfactant? I have noticed just under strict aseptic precautions, 4.5 ml of surfactant given via ET tube. 4 ml you will take from one surfactant 4 ml vial and 0.5 from the another one, and you will keep the remaining 3.5 ml for the next baby. It will be open and kept in the fridge in the NICU. These are the glitches which I found. And regarding post surfactant monitoring care, there was no any definitive monitoring sheet, which is he has to document. If at all he has to document hourly for about 6 hours and every third to fourth hourly, or even he need to motivate his sisters for documentation. Definitive monitoring sheet were not there. These are the glitches. And finally, what was the basic cause of death on those post surfactant baby? Mostly the baby died within 1 or 2 days. So there is a problem in instituting surfactant and immediate post care of the surfactant. So we need to find out and we need to tide over the crisis. So formulate antepartum and intrapartum treatment for any antenatal mothers. Sit along with their OG team. Formulate a plan, antepartum, and if at all, if a mother less than 36 weeks comes, this will be the plan. Will be given tocolytics, will postpone as much as possible. If at all concurrent chorioamnitis, he has to be treated with IV antibiotics. In concurrence, about for past 3 months, what was the growth, which was more common, it has to be selected, it has to be given. Educate and ensure almost not only the consultants, even the CRRIs, OGPGs should be aware about the importance of antenatal steroids, how early, even a single dose may be important. This has to be made aware of. And education, we need to have a policy about the in utero transfer. Definitely government should have a frame a guidelines, because I am sitting in the public sector. You can frame a guidelines, less than 36 weeks, no duty for you to deliver until otherwise the mother has delivered in a precipitate labor. This is what. Then finally, guidelines for early CPAP, guidelines for surfactant therapy, guidelines and monitoring sheet for the babies in the NICU, and anticipate the problem. If at all, if for example, if I found out sepsis was a major care, then what was the organism? What was the sensitivity pattern? Early institution of those sensitive antibiotics, that may be useful. That may be very useful in reducing the outcome, worst outcome. So identify the problem by routine audit, individualize, because you almost multidisciplinary team should be involved and individualized. You should ask what are the hinders you are facing, why this is not happening. You need to collect the data, educate, motivate, and you need to re-emphasize few things. There may be glitches, you need to re-emphasize, execute the plan, measure the fruitful outcome. If at all, if it is not working, reconsider, something is wrong. If you are getting, but the effect is not that much, probably we need to look for where we are lagging. If we have won it was a very fruitful outcome, then take it as a highly motivating point, motivate your team again, work on something else, because life won't be there, our life won't be, definitely our NICU won't be without any problems. So take home points, know what's wrong, create a bundle plan involving all your teams. If not working, recreate the bundle plan, work again till better outcome. Thank you, ma'am. Thank you, one and all.
Thank you, Dr. Sendil, for such an emotional presentation. I think that's part of the work you have done, or things you have gone through. While we take over, we do land in problems, but that should not deter us from finding solutions. I'm very happy that you found solution for one care bundle. But again, I would like to make a comment rather than ask questions to you. Very good work, Sendil. Continue the good work.
Thank you.
And the second one, see, I would like all the primary care pediatricians to take home today one care bundle. That is delivery onto abdomen, keep the baby for skin to skin contact for 1 hour, and within that 1 hour, initiate breastfeeding. These three things would go a long way, which will reduce our mortality in neonatal by 22%. This is simple, but very difficult to implement. We know evidence. Evidence is there. We come and talk in CMEs like this, but how many of us are implementing it? Of course, we need the cooperation of the obstetrician. So it is our duty also to educate the obstetrician, but also be firm on from our side to see that the babies are kept for early skin to skin contact for 1 hour. Like that, each perinatal bundle, including your preterm care bundle, nutrition bundle. I feel we should have a nutrition bundle not only for prevention of NNEC. We should have a bundle for breastfeeding support. What are the actions which we have to do? That is also very, very important. And also identifying and customizing the care bundle to our unit is the most important thing we have to do. Our problem might be much different from what the Western care bundle tells us. Like the simple thing like how surfactant is stored in the medical stores. So we should identify what is our problem in executing those care bundles and make our own solutions, which might be quite different from what the solutions they may have. They may have the solution of a individual TPN nurse that may not be possible in our setup, but we should find an alternative, at least give one TPN nurse for the unit so that she would do the thing, the primary care would be done. So it all depends on how we institute these care bundles effectively so that we could improve the outcomes in our hospitals. As Tamil Nadu, we are doing very well. I won't say that we are bleak, but still our SRS 2018 to 19 doesn't show any improvement either in infant mortality or neonatal mortality. So we should be aware of that as pediatricians. Both taking care of neonatal and postneonatal mortality is our duty today. And I think hope this CME would have given various aspects of neonatal care, which would help in improving the quality of care in our babies. Thank you. Thank you once again for the opportunity. I did not see any questions in the chat box.
Thank you very much, ma'am. It was a wonderful learning experience, I'm sure, for all of us. At least I enjoyed all the topics. So if at all, I'm sure there are others who had such an experience. Thank you very much, sir. Any comments from our Professor Srinivasan, sir? So unmute, sir.
Sir, Dr. Srinivasan.
Unmute, sir.
Yeah, I enjoyed all the talks, though I'm not a neonatologist. Okay, so it was very interesting and of course, a learning experience again. Thank you.
Thank you, sir.
Thank you. I think Viswanathan wants to comment.
Thank you very much, ma'am. Actually, it was very nice having you and Arsad sir, and of course all the speakers who did a fantastic job. Let me conclude the CME by thanking all the members. And any comments from Dr. Vishwanathan? Dr. Vishwanathan, any comments?
No, it's very nice. Thank you. And I learned a lot of things, and particularly this care bundle actually is new to me as well. Actually, I didn't know about this word, care bundles in neonatal intensive care. And thank you. I think it was very useful. And thank you all the stalwarts. Thank you very much.
Thank you. Annamalai sir, any comments, sir?
Annamalai sir? The concept is very good in your primary health center setup. It's very good innovation. So congratulations.
Yes, sir, it is something very useful actually. It makes life easy for the nurses and as much as for us also. Because next day we don't need, we have our expectations well laid out and it's very clear and simple and everybody agrees, and that definitely improves the care at all levels. And I'm very happy actually, Dr. Senthil really highlighted the whole.
Actually, the care bundles is not only for NICU. That's what I'm saying. At all
Yeah,
levels.
yes, ma'am. Yes, ma'am. It has to be for primary care, ma'am.
Yeah.
Like in our hospital, even for not for NICU, for routine ward babies, there is specific to say they have to be fed within 1 hour. They have to be given breastfeeding, check blood sugars, check temperature. Those kind of stuff is already written there.
Even before a discharge care bundle.
Yes, ma'am.
Before discharge.
Even for discharge, like similar one. So thank you very much, and
we have to congratulate speakers as well as the plan person Tirumurugan who planned the whole thing.
Thank you, sir. Thank you very much. Hope to see you again next.
Untiring, sir. There is untiring.
Thank you, sir.
Yeah.
Thank you for the opportunity.
Thank you, sir.
Dr.
Thank you very much, Dr. Sandra. And Dr. Abhiram, actually, she had prepared some MCQs, but unfortunately, it got missed out. But we can still project it actually on the polls. So if I can, we can just launch it. I just launched it. If people to answer. This is from her talk. Actually, we wanted for all, but unfortunately, didn't have enough time to organize. But at least, and then she can go through those questions. There are 4 questions from her talk.
I'm doing it.
Thank you.
ஒரு 3 क्वेश्चन தான் பார்க்க முடியுது. அதுக்கப்புறம் கீழே போக மாட்டேங்குது. போதும். Thiru, you're muted. Thiru, you're muted.
Sorry, thank you. I'll just share the results for everybody to see. Can you just see the results?
Yeah, we can.
You can, no?
Yeah.
So, Dr. Abhiram, do you want to just discuss the questions?
Yes, sir. So the first question is the reasons for inadequate breastfeeding skills in late preterm neonates. So the options are low muscle tone, weak suction pressure, falling asleep early in feeding, and all of the above. So the answer is all of the above. And the second question is weak sucking of the baby is a risk for impaired lactogenesis in the mother. So it is a true or false question, and the answer is true. So weak sucking of the baby is a risk factor for impaired lactogenesis in the mother. Then supporting the head and neck and swaddling the baby helps improve breastfeeding in late preterms. So the answer is true again. Then the fourth question is expected weight gain for a late preterm neonate is 13 gram per kg per day.
Okay. So thank you very much. Hopefully we will have a better planning from next time onwards. So thank you, and see you all in the next CME. Thank you very much, ma'am. Thank you, sir. Thank you.
Thank you so much.